Midwives Advisory Board meeting to order, and it is 10:02 a.m. Please, everyone, mute your microphone and only turn on when it's your turn to speak. Keep your camera on and announce your name when speaking so your name can be recorded. And I will call on Carmen Marshall to conduct the roll call.
Danielle Hurst.
Present.
Kristen Bowers.
Present.
Gretchen Robinson.
Present.
Jennifer Kelleher. Michelle Gold.
Here.
Melissa Bates.
Present.
Dr. Guillory.
Present.
Glad to see you, ma'am.
Good morning.
Dr. Nix.
Present.
And Presiding Officer Destiny Hooper.
Present.
We have a quorum.
All right. I would like to introduce our newest board member, Danielle Hurst. If you want to take a few moments to introduce yourself.
Sure. Good morning, everybody. My name is Danielle Hurst. I am from South Texas. I come to you with an investigative background, conducting federal investigations with the nexus to midwife cases. So this advisory board is very important to me. I am very happy to be a part of this group, and I do look forward to hearing from and learning from all of you. And I hope to shed, just a little bit of light from a different standpoint. But I am really, really excited to be here with you guys today.
Thank you. And I will now call on the Assistant General Counsel, Athena Ponce, for the open government training.
Good morning, everyone. My name is Athena Ponce, Assistant General Counsel with TDLR. I'm going to be presenting the open government training today. We did present this training earlier this year, but since we do have a new member, we will be presenting this training again for everyone. So if you'll bear with me, I will be sharing my screen in just a bit, and we will go through the training slide by slide. Can everyone see this blue PowerPoint slide? Okay, great. So I will be providing an overview of the Open Meetings Act, the Administrative Procedure Act, and the Public Information Act. Here are some nuts and bolts of the Open Meetings Act. The purpose of the Open Meetings Act is to ensure open and transparent government. The Act requires meetings of governmental bodies to be open to the public and to be preceded by public notice of the time, place, and subject matter of the meeting. The provisions of the Act are mandatory and are to be liberally construed in favor of open government. Some key concepts of the Open Meetings Act involve a quorum. A quorum is a majority of the members of the advisory board or committee as fixed by rule or statute. A quorum of a governmental body, including an advisory board or committee, must meet in order to take an official action. If less than a quorum meets, the board or committee may have discussion but may not take any official action. As to deliberation, a deliberation or a discussion means a verbal or written exchange among a quorum of a governmental body or between a quorum of a governmental body and another person concerning an issue within the jurisdiction of the governmental body. Another key concept is meetings. A meeting occurs anytime a quorum of a governmental body engages in deliberation regarding public business or public policy over which the governmental body has supervision or control, or any time the body takes formal action. Another important item is notice. The Act requires advance written notice of the date, time, place, and subject of each meeting held. TDLR provides this notice in the form of an agenda. Notice must be filed with the Texas Secretary of State at least 7 days before meeting and must be posted online both by TDLR and the Secretary of State. A board or committee may not engage in discussions about a subject not included in the agenda. So here's a question: what about social functions, conventions, and workshops? Keeping in mind that a meeting occurs whenever a quorum of a governmental body engages in discussion about an issue within the governmental body's jurisdiction, can members ever meet in an informal setting without violating the Open Meetings Act? Yes, members are free to engage in conversation that is incidental to the event. However, the discussion will be subject to the Open Meetings Act if a quorum of members is involved, and the members either engage in a discussion or make decisions about board or committee business or take formal action. Key points to remember about this are to always be aware of any situation occurring outside of a properly noticed meeting in which a quorum of members is present or engaged in discussion. Do not engage in substantive conversations relating to board or committee business or policy when a quorum is involved and you are outside of an officially noticed and scheduled meeting. Also, to keep in mind, beware the walking quorum. A walking quorum occurs when fewer than a quorum of members engage in discussion about official business and then communicate those discussions to other members. While fewer than a quorum of members participate in the initial communication, subsequent communication with other members will result in a quorum discussing official business outside of a public meeting. So here's some examples. On a 5-member advisory board, 2 members exchange phone calls and emails expressing thoughts on an upcoming rule change and exchanged research that they have each individually performed regarding the issue. One of the board members subsequently forwards the exchange to another member. The members have now engaged in a walking quorum by engaging in a small group discussion outside of a properly noticed board meeting. Walking quorums can occur during conference calls, video conferences, hallway discussions, emails, text messages, and other new technologies. The walking quorum concept combined with newer technologies such as Twitter, Facebook, and instant messaging raise new issues about meetings and compliance with the Open Meetings Act. Here are some best practices to avoid a walking quorum. To avoid a walking quorum, members should not meet in small groups, discuss board or committee business, and then communicate those discussions to other members. Send emails or text messages to a quorum of members regarding official business, even if each email is addressed and sent to each member individually. They should not create posts on social media about board business where a likelihood exists that a quorum of members could participate in discussions, or ask a quorum of members, even on an individual basis, for feedback or comments on board or committee business outside of the public meeting. This is also called polling, which is essentially conducting an informal vote on an issue. Here are some guidelines for open sessions. A board or committee is limited to discussing the specific items on the agenda. During the public comment portion of the meeting, members of the public are given an opportunity to speak, and the presiding officer may set reasonable limits on commenters. A member of the public or a member of the board may raise a subject that has not been included in the agenda. However, Any discussion of the subject must be limited to a proposal to place the subject on the agenda for a future meeting. Now, here are some guidelines for open sessions best practices. To avoid violating the Act on the basis of insufficient notice, members should limit discussions to the specific agenda items contained in the posting filed with the Secretary of State. Avoid allowing discussions regarding specific agenda items to wander off course into new issues that have not been noticed to the public. Not respond to or discuss issues that are raised during public comment but which are not on the agenda. Specifically identify items for future agendas and communicate those items to TDLR staff. And I will also mention today, under statute, board members may not discuss the specifics of open investigations, pending litigation, contested cases, pending complaints, or the individuals involved in those matters during an open meeting. These matters are or may be confidential by law under Occupations Code 51.254, and we may not discuss them freely in an open public forum. There are penalties and remedies for Open Meetings Act violations. Civil remedies are shown as any interested person, including the media, may petition the courts to stop actions taken in violation of the Open Meetings Act. The Open Meetings Act also specifically states that an action taken in violation of the Act is voidable. Some penalties are described here. Members who knowingly participate in a walking forum or who knowingly participate in a meeting that is closed to the public are subject to misdemeanor criminal penalties. The penalties are a fine of $100 to $500, confinement in county jail for 1 to 6 months, or both the fine and jail time. Here are some Open Meetings Act best practices. Avoid communications that involve a quorum of board or committee members about official business outside of a properly noticed public meeting. During open meetings, confine discussion to items specifically posted on the agenda. Here are some resources concerning the Open Meetings Act. A link to the Texas Attorney General Open Meetings Training Information and Video, the Texas Attorney General Open Meetings Handbook from 2024, the Texas Government Code Chapter 551 Open Meetings, and the phone number for the TDLR General Counsel's Office. Next, we are moving to the nuts and bolts of the Administrative Procedure Act. The purpose of the Administrative Procedure Act, or the APA, is to establish minimum standards of uniform practice and procedure for state agencies, and to provide for public participation and transparency during the rulemaking process. The APA definition of rule is a statement of general applicability made by a state agency that implements, interprets, or prescribes law or policy, or describes the procedure or practice requirements of a state agency. A rule excludes a statement regarding only the internal management or organization of a state agency and not affecting private rights or procedures. A rule includes a new rule, an amendment to an existing rule, and the repeal of an existing rule. Sources for rulemaking include legislative changes, advisory boards, TDLR staff, 4-year rule review, and rule petitions. A rule petition involves any interested person who may submit a petition to a state agency requesting the adoption of a rule. An interested person is anyone who is a Texas resident, a business entity located in Texas, a governmental subdivision in Texas, or a public or private organization that is not a state agency but is located in Texas. Here's a chart showing the steps in the Administrative Procedure Act rulemaking process. As you can see, it starts on the top left of Rule Idea and Drafting and moves to Internal Review and Analysis, followed by Review by the Governor's Office, and then the first Advisory Board meeting. Then the proposed rules are filed with the Secretary of State and the Plain Talk summaries are posted. The proposed rules are published in the Texas Register, and then there is a 30-day comment period. Afterwards, there is a review of public comments, and then there will be a second advisory board meeting. The proposed rules are adopted at the commission meeting afterwards if those rules went to the commission. There is an adoption notice filed with the Secretary of State and published in the Texas Register, and there will be an effective date of the rules. The rule review process under the Administrative Procedure Act involves programs that are on a 4-year schedule for review. There will be a notice of intent to review, and the public will have 30 days to comment after that notice. The General Counsel Division then reviews comments and makes a recommendation to the Commission. The Commission will review rule filings and comments and may re-adopt the rule. The Advisory Board will be presented any comments and may recommend changes. Here are some resources regarding rulemaking. Again, the Texas Attorney General's Office, a link to Admin Law Rulemaking Chapter 20 for the year 2022, Texas Government Code Chapters 2001, 2006, and 2007, Secretary of State website, Texas Register, and Texas Administrative Code, and the phone number to the TDLR General Counsel's Office. Next, we'll discuss the nuts and bolts of the Public Information Act. The Public Information Act, or Open Records Act, is intended to allow public access to information about the affairs of government and the official acts of public officials and employees. The Act makes all documents, records, and other information relating to official business open to the public with some exceptions. Public information includes any electronic communication created, transmitted, received, or maintained on any device if it is in connection with official agency business. The Act should be construed liberally in favor of granting requests for information. The open records process involves a request for public information. The public may request copies of public information or request to inspect the information in the offices of the governmental body. A request must be submitted in writing. At TDLR, a request must be submitted through the TDLR Record Center, which can be accessed on the TDLR website. Under prompt response requirement, TDLR must respond to the request as soon as possible, but not later than 10 business days after receiving the request. We cannot ask why someone wants the records. We can only ask for clarifications through the General Counsel Open Records team. There is a general rule and then some common exceptions to disclosure. The general rule is a presumption of openness. However, certain information is required to be redacted from open records. Examples include dates of birth, most email addresses, driver's license, license plate, and VIN records, credit card numbers, HIPAA information, and Texas Medical Records Privacy Act information. An Office of an Attorney General ruling must be sought to redact or withhold other information. If there is a request received by an advisory board member for records, if you receive a written request for records or correspondence that looks like a public information request, please forward the request ASAP to the advisory board team, who will forward it to the Office of General Counsel Open Records team. If the GC Open Records team requests information from you as an advisory board member, please respond as soon as possible. The 10 business day deadline applies to all requests. Here are some resources relating to Public Information Act. A link to Texas Attorney General Public Information Act training, information, and video. Texas Attorney General Public Information Act Handbook from 2022. the Texas Government Code, Chapter 552, Public Information, the phone number for TDLR General Counsel's Office, and the TDLR Open Records Policy link. Are there any questions about this presentation?
Thank you, Ms. Ponce. We will move on to the approval of minutes from the meeting
Sorry.
of January. Oh,
Sorry, Michelle Gold here. I tried to raise my hand for questions, but it didn't go through. Is it okay if I still ask a question?
Mhm.
Okay, great.
Yes.
For the public comments and putting the issue of public comments on the next agenda, how much, if we're still in the meeting and want to put an item on the next agenda, how much are we able to share about the issues from the public comments if we can't talk about the public comments during the meeting? Can you clarify that?
Is it okay if I defer to Derek on that subject, Derek Burkhalter? This is Athena Ponce, Assistant General Counsel speaking, and I think Derek Burkhalter would be able to better answer that than I can right now.
Thanks.
Yeah, hi, good morning. I'm Derek Burkhalter, Assistant General Counsel with TDLR. So the question is, how are you supposed to recommend a meeting agenda item without being able to talk about the comment?
Right. Yes.
Okay, yeah, I mean, if the comment brings up a subject matter that you would like to discuss in a future meeting, then, I mean, you can just generally state that you would like to recommend that subject be an agenda item for the next meeting, but without going into the details. It's just more about, we can't have like a back and forth exchange about something that's not on the agenda.
Okay.
But because that agenda item would be discussing possible topics for the future, it would be appropriate to talk about it at that point.
Okay, great. Thank you.
Mhm.
does anyone else have any questions? Okay, so we will move on to agenda item D, the approval of minutes from the meeting of January 13th, 2026. Does anyone have any comments regarding the minutes? I'll ask for a motion to approve the minutes
I'll make a motion to approve the minutes.
in a second.
Second,
Thank you.
Who was the second? I'm sorry.
Kristen Bowers.
Thank you.
Ms. Marshall will do a roll call vote.
Danielle Hurst,
I approve.
Kristen Bowers,
Yes, approved.
Gretchen Robinson,
Approve.
Jennifer Kelleher,
Approve.
thank you. Michelle Gold,
Approved.
Melissa Bates,
Approved. Approved.
Dr. Guillory,
Approve.
Dr. Nix,
Approve.
and Presiding Officer Destiny Hooper.
Approve.
Motion passes.
Thank you. All right, at this time, we will do the public comment section. We received 174 written comments that were emailed. In a second.
Second,
Thank you. Sorry. We received 174 written comments that were emailed. Sorry. All right. We received 174 written comments that were emailed to the board before the meeting. These comments will not be read during the meeting and cannot be discussed. The Midwives Advisory Board did receive 11 requests to speak during today's meeting. The board will not be allowed to ask questions or discuss anything said. Okay. And they're here in the I'm going to read the instructions for the public commenters. Thank you all for being here. When I call your name, please begin by stating your name and who you represent. Each speaker has 3 minutes to address the board. Carmen will be our timekeeper. Please note that board members may ask only clarifying questions, but are not allowed to engage in a discussion with you. Additionally, please be aware that certain matters cannot be discussed in an open meeting, including specific information about open investigations, contested cases, and pending litigation. Comments should not identify or discuss specific individuals involved in such matters, including complaints, respondents, witnesses, or agency staff. So we'll start with Annie Coots. Do you understand these instructions? And if so, please start when you're ready.
Yes, I understand. My name is Annie Kuntz. I'm representing my solo midwifery practice, Attuned Midwifery Services. I reside and practice here in El Paso, Texas. I've been a certified professional midwife for 19 years and have been a licensed midwife in the state of Texas for 15 years, practicing both in birth center and home birth settings. I've worked hard in my community to establish safe practices for my clients and their babies, as well as working with our local hospital staff and other professionals for consultation, referral, and transfer of care when necessary in order to have safe practices and smooth um, outcomes for my clients and their babies. I'm concerned about some of the actions that have been happening recently through TDLR, specifically related to complaint and disciplinary processes and how it relates to the midwifery care that we provide in our communities. Recently, there's been more fear and concern in the midwifery community, at least amongst my colleagues that I'm in contact with, regarding certain disciplinary actions that have been taken. Of course, we don't know the details of some of these cases, so I can only speak to what the perception is in the community. It does feel like some of these situations have not been conducted in a way that might be aligned with the policies that have been um, laid out. Again, I'm not privy to details, so I'm not sure exactly how things are being done, but it seems like there may be a lack of transparency or understanding between the board and the community of midwives about how disciplinary actions are handled and how investigation is brought forth. I bring this concern because I want there to be normal, healthy investigative practices and a lot of transparency and clarification between the Midwifery Advisory Board and TDLR and the community of midwives. Um, the investigative process should match what is described in the TDLR policies. And this lack of transparency, I think, is creating a lot of nervousness and discomfort within the midwifery community. And I worry that that discomfort is going to have midwives leaving our communities and not practicing and not continuing to serve our communities. It's not clear to me as a practicing midwife exactly what the processes are regarding investigation and disciplinary action. Um, I want to make sure that as
Time's
midwives
up.
practicing that we have the ability to have a little bit more understanding.
Thank you, Ms. Coons. Ms. Marshall said your time is up. I'm
Oh,
so
okay.
sorry.
Oh, that's fine. Thank you.
Thank you. All right. Next, we will call Cassie Lewis. Do you understand the instructions? And if so, please start when you're ready.
I do. Yes, my name is Cassie Lewis, and I represent myself as a private citizen who has used midwifery care. Thank you for opening up this meeting today to hear from outside voices. I know in my line of work, I can get caught up in what seems like a tornado of details and decisions to be made in hopes of doing so with the highest amount of efficiency possible. And I can quickly forget that those decisions step off the paper into real life and affect real human beings. So I hope that hearing from myself and others today, that you feel the weight and responsibility of your job, that of the well-being of the thousands of women and babies who could be affected by your decisions on this board. Of the nearly 400,000 live births in Texas each year, we know about 2% of those will birth out of the hospital with a midwife. On the Texas Constitution and Statutes website, Chapter 203 Midwives, Section 203.003, point 1, there's 3 points. A parent has the responsibility and right to give birth where and with whom the parent chooses. Childbirth is a natural process of the human body and not a disease, and midwifery has been practiced in this state since the days of the Republic. Between the years of 2012 and 2023, I personally received prenatal care, labor and birth support, and postpartum care for 4 babies out of the hospital with a midwife here in Dallas. I hope that my daughters, future daughters-in-law, granddaughters, and so on will have the same rights put forth in point 1 that I read above of section 203.003. It is imperative that you use this section in chapter 203 as a paradigm when making decisions about licensing and regulation of the vocation of midwifery in Texas. The nearly half of the state that is considered a maternity care desert needs you. The mothers seeking high-level continuity of care need you. The mom, who was me a few years ago, who is going through her first miscarriage and needs her midwife to sit on her bed with her for 7 hours and talk, laugh, and cry with her, needs you. Simply put, we need more midwives in Texas, not less. You have the opportunity to be part of encouraging and supporting safe and well-educated midwives, yes, but also practitioners of an ancient art that transforms the lives of women and by extension, whole families and whole societies with good, true, and beautiful care. They all need you. They all need this advisory board, all of these mothers, to be brave, countercultural, wise, and humble when viewing midwifery care. So, do we want to continue to be in the top third of maternal mortality rankings in this country? Or do we want to find a better way for the good of women, babies, families, and Texas society at large? Thank you so much for your time.
Thank you so much. All right, next we have Miss Amanda Calicut. If you understand the instructions, please start when you're ready.
My name is Amanda Calicut, and I am representing myself as a mom who was under the care of midwifery. And I also represent Moms Advocating for Moms Alliance. I am deeply concerned about the amount of time it's taking for TDLR to process complaints. There are 2 cases involving death that are 1,100 days old and 900 days old. The 900-day-old case hasn't even had a notice of alleged violation issued. During these extended timeframes, other families have lost their children or had extreme outcomes, including hysterectomy, weeks-long ICU and NICU stays. I'd also like to address something that was said in the previous meeting about the number of complaints involving death. I know a handful of mothers who have lost their children whose complaints are still open and pending, where no action has been taken. The families have not received any updates aside from the generic letters that get sent out saying that the case is still open. Those midwives are still practicing. It has also been brought to my attention that midwives across the state are advocating for manipulation of the complaint system. They want to decide who can and cannot file complaints by mediating between the client and their midwife to determine if any wrongdoing occurred and whether there should be a complaint filed. Silencing mothers is only beneficial to the midwives. As a mother and advocate for families in Texas, I can assure you that most families don't file complaints because they are ridiculed in the community if they even mention their less than stellar out of hospital birth experience. And they also have no faith in the TDLR or the enforcement process. I'd also like to assure the midwifery community that Mama is not advocating for the dismantle of midwifery in Texas. We want TDLR to do better. We want midwives to hold each other accountable. We want midwives to practice safely. We want data to prove the safety of out of hospital birth, and we want options for mothers all over Texas. Thank you.
Thank you, Ms. Calicut. Next, we will call Jamie Hinton. Do you understand the instructions? And if so, please start when you're ready.
Yes, thank you. I'm Jamie Hinton, a licensed midwife in the state of Texas, licensed for 10 years. I'm here representing myself as a licensed midwife and also Mama as a board member. I would like to address the board today with the statement that as a licensed midwife, I would hope that in the event of a death, that my practices would be investigated. As a licensed midwife, I would like it to be known that I do not support the stance that the state is on a witch hunt, and I do not support the widely held belief that consumers and families who have been harmed by midwives are telling untruths or trying to shut midwifery down within the state of Texas. Attempting to silence those who have been harmed by midwifery and elevate those who have had positive experiences with midwives does not help in acknowledging or solving the safety concerns that are prevalent. The state is not aware of how many deaths there are to families who are under the care of a licensed midwife. This is one of many changes that need to be made to increase accountability and safety within our licensure. Please do not allow the voices of those who have had valid concerns and tragic losses to be drowned out by the majority of those who have positive experiences. Most births of low-risk people will go well, we know that. This does not negate the fact that negligent and unsafe care happens and that mothers and babies are suffering due to that. I have become aware of another neonatal death that has occurred in the recent week in my local community under the care of a licensed midwife. It bothers me that the state will not be aware of this unless a complaint is filed by a grieving family or someone who is brave enough to step out and do that. These are things that need to change. I implore you to create a system where all deaths are investigated, not for taking the option of midwifery from consumers away, but for improving the standards, safety, and accountability of midwives. Thank you.
Thank you, Ms. Hinton. Next, I'll call on Stacy Anderson. Do you understand the instructions? And if so, please start when you're ready.
Yes, one moment. Having my husband take the baby so I can talk for a few minutes. Thank you so much. I am listening to all the comments and I don't have any comments scripted. I just was asked recently if I'd be willing to speak up and just share my feelings about midwifery care. And I have 3 children that I used midwives for. And yeah, so everything I'm hearing about all the licensing, it just the idea that it would be hard for me to get a midwife and to feel comfortable with who I'm choosing for my care just like sent this little like vein of terror through me. Yeah, I just been thinking about, gosh, I don't even know what to say. But when I first got pregnant, we struggled with getting pregnant, and it wasn't until I was 37 having my first, and I knew a lot about infertility, but I didn't know about then, okay, getting the baby out. And so I just chose my sister-in-law's OBGYN. I went to the doctor and checked my cervix, and I asked him all the questions, should I do Lamaze? Should I do this? Should I do a preparation? What's the preparation, and how's it all going to go? And he's like, don't worry about it, we'll just get the baby out. And I just kept asking questions, and he's like, whatever you prepare, it'll just all go out the window, and you just come to the hospital, we'll get the baby out for you. And that terrified me. I had a panic attack in the car driving home with my husband, and I said, I can't do this. So then I started researching, and I need to feel empowered. And my 3 births with midwives were the most terrifying and thrilling and amazing experiences of my life. And just the idea of having less accessibility to a midwife in the future it would be really difficult for me. I think about, it's already been said about the future. And I think we live in a society and in a time and age in history where women are more empowered than they've ever been before. And so listening to everyone, yes, I want safety for everyone and the ability to choose. And so that really for me is what is the most important thing, the ability to choose. And I interviewed my midwives and was well aware of their credentials and of their history and how many births that they had attended and everything that they were, the scope of their practice. My midwife collaborated with other healthcare professionals to help me with all the issues that I went through. And so this is something I know I don't speak up. I represent myself just as a mom. I don't normally speak up around things, but this is one of those things I thought, okay, if I can just say midwifery is important to me and I want to continue to see it accessible and safe, whatever that means, that I think it's amazing that there's a licensing board, that these things are regulated.
Time's up.
Okay, thank you so much.
Thank you, Ms. Anderson. Next, I will call on Roxanne Anderson. Do you understand the instructions? And if so, please start when you're ready.
Yes, thank you. My name is Roxanne Anderson. I've been a licensed midwife in Texas since 2012. I'm a member of ATM NTM, and I am the current president of NARM, the North American Registry of Midwives. I represent myself and my own opinions today. From both the national and state levels, we're watching what's happening in Texas with both interest and concern. The Professional Credential CPM, Certified Professional Midwife, or the NARM exam, is now written into the legislation of 40 states, including Texas. This credential was specifically developed to create a consistent standard of skills and knowledge for non-nurse midwives practicing in America. We currently have over 3,000 active CPMs, and many of those are in Texas. As you've already heard and know, America has a healthcare crisis that hits mothers and babies particularly hard. Our maternal and infant mortality rates are among the highest in high resource countries. And no wonder, in Texas alone, half of all counties lack practicing obstetricians or delivery facilities. Community midwives are the obvious solution. We work well in low resource areas, and there is abundant evidence that when we provide care, outcomes improve on a large scale. And we save the state millions, if not billions, in that process. In short, Texas needs licensed midwives, and Texas midwives need the backing of their state. The states with the best birth outcomes and the most successful midwifery programs are marked by one thing: cooperation. Cooperation between professional midwife organizations and state licensing and regulatory agencies, cooperations between licensed midwives and nurse midwives, and cooperation between hospital-based birth providers and home and birth center birth providers. Texas has long been ranked at high as a choice for consumers who want the option of home and birth center birth with a licensed midwife. Every midwife I know, myself included, has clients who have moved here from another state just so that they have the option of a home birth with a licensed midwife. And this is why when both midwives and consumers see that cooperation and support framework for licensed midwives in Texas shifting, we have deep concern. There are those at TDLR, not everybody, and I do acknowledge that, but there are those who have been very open about the fact that they don't personally like midwives. There are others who are actively trolling social media for evidence to file complaints. Proposed changes to the informed consent agreement are blatantly misleading and punitive, and this is alarming to midwives and their clients, and it also erodes public trust in the regulatory process. Right now in Colorado, midwives are suing their regulatory board over making it increasingly difficult for them to maintain their licenses. Similar lawsuits are happening in Alabama, Mississippi, and Georgia. We would prefer Texas to not be on that list. So we are challenging TDLR to stop overstepping and return to its former efficiency and impartiality in issuing our licenses. Thank you.
Thank you, Ms. Anderson. Thank you so much. All right, next I will call Miss Lee Blankenberg. Do you understand the instructions? And if so, please start when you're ready.
You're muted, ma'am. Yeah, you're muted, Leah.
Sorry.
We
Okay.
can start
Yes.
again.
I'm sorry. Sorry.
Regroup
Yes,
and then
I do understand. I am here to represent myself, my experiences receiving care from my licensed midwife. I have given birth to 6 living children, and the younger 5 received care for our home births from my licensed midwife, Toni Kimball. I have known Toni now for over 17 years. I came to know her after I had a miscarriage after our first living child. I felt that God was leading us to a more holistic care for my pregnancies because the first thing that Toni asked me in regards to my miscarriage was, how was my nutrition? To date, Toni has delivered well over 1,200 babies in the last almost 30 years of her practice, with about 400 at her birth center. Personal care that is given from a midwife is of no comparison to the care that I receive from my OB-GYN in regards not only to nutrition, but in also helping me to have healthier pregnancies. Toni stays very up to date on all of her continuing education, and I gave birth to all 5 of my younger children at our home. My OB-GYN agreed with me that when the mother and the baby are both healthy, that they should be able to give birth wherever they would like to give birth. My first birth was only in a hospital because I didn't know about midwives at that time. But midwifery care goes beyond just taking care of the mother and the baby at birth. Toni was available to me through calling, texting, and emailing outside of appointment times if I ever needed to get in touch with her or had a question. I had 3 miscarriages in between our 5th and 6th living children, and I had 4 miscarriages after our 6th living child. Those were due to secondary infertility from an autoimmune thyroid disease. My doctor treated me for my thyroid issues, but I did not need any medication for any of my miscarriages. Toni helped me manage care through all of those miscarriages, and the professionalism and support that she gave, along with any emotional help that I needed, just speaks volumes to the kind of care that a midwife gives to her clients. Toni's organizational skills were unparalleled, as I was given a folder for every single pregnancy. She kept an identical folder, and I always knew of all of my statistics from every appointment for blood pressure, fundal height, weight, etc. She was very attentive to all of my needs, and I always felt so comfortable whenever she did any blood draws. She was very thorough in explaining everything for how the baby was positioned, or helpful hints that you just don't always get in the obstetrics office. She never pushed me for something that I did or did not want to do, and always offered a less invasive approach. I always felt safe with Toni, and her experiences provided such a calm atmosphere. One of my most favorite aspects of having access to a licensed midwife, though, is not only that I have the option to birth in my own home, even though she does have a birth center, but Toni came to see me within 24 to 48 hours after giving birth to make sure that breastfeeding was going well and that I was recovering well, not only physically, but emotionally. She then came a few days after that, and then at a week's time postpartum. I was able to go see her with the babies at 2 weeks for a checkup, and then she did our 6 weeks postpartum checkup for me and the babies. I never had that care outside of using a licensed midwife. The attention to detail is just unparalleled. Maintaining access to licensed midwifery care is essential for all Texas women to have the same options that I had for my pregnancies and births, and even the care that was given to me through my miscarriages. Thank you.
Thank you so much. Next, we will call on Christina Maldonado. Do you understand the instructions? And if so, please start when you're ready.
Yes, I understand. My name is Christina Maldonado. I represent myself. I'm a student midwife in Texas, and also Tiffany Toe, licensed midwife in CPM. So thank you for the opportunity to comment on proposed changes to the state-required informed disclosure for midwives. Texas has regulated licensed midwifery for decades, and its purpose is to promote public safety. Improvements can and should be made. However, any change must be evaluated for whether it actually increases safety and whether it aligns with the Texas Midwifery Act of 1991. The proposal to add language about the possibility of litigation into the initial informed disclosure does not meet those goals. Introducing legal threat at the first interview fundamentally alters the nature of midwifery care. The midwifery model is built on informed choice, continuity, and relationship-based care. This is not a stylistic preference. It is part of the statutory framework that protects access to midwifery in Texas. The legislative finding under the Midwifery Texas Act is that a parent has the responsibility and right to give birth where and with whom they choose. Childbirth is a natural process and not a disease, and midwifery has been practiced in Texas since the Republic. These findings establish that Texas protects access to midwifery as a distinct model of care. Any regulatory change must respect that legislative intent. But the proposed disclosure language does not address current concerns and does fall short. Simply informing clients that they may sue a midwife does not improve safety, does not clarify legal processes, and does not ensure standard of care compliance. It provides no actionable information for consumers and does not strengthen accountability. Parents make the safest decisions when they have meaningful data, the midwife's current stats, outcomes, and practice information. Only the parent can integrate that information with their own medical history, preferences, and values. Empowering parents with accurate data conforms with the Midwifery Act and strengthens consumer protection. A more effective legal and lawful regulatory improvement would be requiring midwives to submit annual statistics to a functioning midwifery board, with those statistics made publicly available. A disclosure directing parents to that information would genuinely support informed decision-making. Regulation cannot undermine the parent's statutory responsibility and right to choose a provider or the midwifery model itself. Shifting that first interaction toward litigation does not increase safety and does not reflect the legislator's intent in Chapter 203 of the Midwifery Act. It risks restricting access to midwifery
Time's
care
up.
without providing any measurable benefit to mothers or
Time.
babies.
Thank you, Ms. Christina Maldonado. Next, I will call Lori Fremgen. Do you understand the instructions? And if so, please start when you're ready.
I do, thank you. Madam Chair, members of the board, my name is Lori Fremgen. I'm a licensed midwife and former chair of the Midwives Advisory Board. I served on the board for 25 years, helping it transition from Texas Department of State Health Services to TDLR. I want to begin by recognizing the mission of TDLR: to protect the health and safety of all Texans, ensure that they are served by qualified and skilled professionals, provide common sense regulatory guidance to licensees and customers. TDLR is bound to transparency and open government. These values matter deeply, especially in professions that serve families and vulnerable populations. I have seen firsthand the effort required to integrate a complex and nuanced profession like midwifery into a broad regulatory framework. Because midwifery exists at the intersection of healthcare, informed consent, cultural tradition, maternal outcomes, and individual liberty, the promise of a fair, balanced, and innovation-driven regulatory approach and TDLR's role as a neutral arbiter of regulatory law is critically important. Concerns within the community about state employees concealing their identities in order to fish for violations have created fear and mistrust among licensees. Professionals should feel regulated fairly, not surveilled and presumed offenders. TDLR regulates many professions and should remain neutral toward all of them. Just as the agency does not align itself with groups opposed to barbers, electricians, or behavior analysts, commissioners should avoid private meetings with or facilitating introductions between anti-midwife groups and legislators in ways that could create the appearance of bias against a licensed profession under TDLR oversight. The Commission's credibility depends on maintaining clear neutrality. Licensees and the public alike must trust that TDLR applies the law evenly, transparently, and without political favoritism. I recognize that TDLR faces pressure from every direction. That pressure is unavoidable in public service. However, the agency's own core values provide the roadmap forward. I remain hopeful because I believe TDLR has the ability to lead with professionalism, neutrality, and integrity. The agency can continue protecting the public while also respecting the profession it regulates. Thank you to the board and TDLR for your service. Thank you.
Thank you, Ms. Fremgen. All right. Next, we will call Maggie Napier. Do you understand the instructions? And if so, please start when you're ready.
Yes, I understand the instructions. I'm here today to represent myself, my own county in Texas, and the many counties I work with across the beautiful state of Texas. I've been in business for 10 years. I own a peer midwifery billing. So I've worked with both OBGYNs, with midwives, with insurance clients. And so when some of my clients were telling me about the proposed bill number 4553, I was very concerned. I was even more concerned when I printed off this entire document. When reading each requirement that is just for midwives, not for our OBGYNs, but just concerning our midwives, I was very concerned because I myself live in a county where we have a maternity care desert. And for those who are not aware of what a maternity care desert is, it is specifically an area where women lack access to essential maternity care services. No hospital setting, no OBGYN, no birth center, no midwife. These counties are spread across the state of Texas. So much so, we have a printout. In 2025, all of these red counties are counties where we have no access to maternity care. This is a very big problem. It is one of the main reasons we see an increase in maternity mortality. So for me, it was a concern because I work with insurance companies, and so many times we can secure an in-network exception based on a network deficiency for midwives, for hospitals. In my own county, I have to travel an hour to get to a hospital, one of which is Nacogdoches County. We have two hospitals. One closed down their labor and delivery unit. The other, thankfully, still has labor and delivery. However, when clients are sent to that hospital, they're laboring in the halls because there's simply not enough beds. This is widespread all over the state. So for me, it's important that we consider this bill is going to force midwifery out of the state. All of these red counties, they're still going to go without access to care. Midwives, as we all know, fill in those gaps. Those home births in those red counties, those contribute to so many births that we have covered by insurance, by the way. A multi-million-dollar industry who has very strict restrictions on what type of claims are covered. They're covering our CPMs, they're covering our LMs. Blue Cross Blue Shield of Texas, one in particular for the past 10 years who has been such a stickler for not wanting to cover our CPMs, they're doing it. They're making those exceptions. So for me, my concern is that this bill is not built to protect women, but instead, this bill is meant to force out midwifery in the state of Texas, and that's a problem. So my concern is the increase in maternity mortality if bill number 4553 passes. This bill is not well designed. Thank you.
Thank you, Ms. Napier. Next, we will call on Cynthia Lynch. Do you understand the instructions? And if so, please start when you're ready.
Hi, good morning, and thank you for allowing me to speak today. I'm a psychiatric mental health nurse practitioner practicing here in the state of Texas, and I'm speaking today as both a healthcare professional and as a family member whose recent experience reinforced for me the importance of preserving access to legal, regulated midwifery care in our state. My daughter-in-law recently delivered a healthy baby after a successful VBAC following 3 prior cesarean deliveries. During her most recent pregnancy, she was informed at approximately 36 weeks that after this cesarean delivery, she would be undergoing a tubal ligation to avoid future pregnancies because of the risks associated with multiple surgeries. She was not asked, she was told. This was devastating to her and not aligned at all with her goals for her family. She then began seeking out alternatives and was ultimately dropped from her OB's care. What troubled me most was not the discussion of the risk, but the lack of meaningful shared decision making. She did not feel adequately informed, heard, or supported in exploring alternatives by her OB. She ultimately found a licensed midwife who carefully evaluated her individually, discussed the risks and benefits transparently, and provided appropriate monitoring and care. What made the greatest difference in her experience was not simply where she delivered, but the quality of the relationship she had with her provider. She felt informed, respected, and actively involved in all decisions regarding her own care. As healthcare professionals, we often talk about patient-centered care, informed consent, and shared decision-making. Licensed midwives embody these principles. As a psychiatric provider, I also understand the profound impact that healthcare experiences can have on mental and emotional well-being, especially in regards to birthing experiences. When patients feel dismissed or excluded from important decisions, we see higher incidences of postpartum depression, anxiety, trauma responses, and medical mistrust. Texas faces significant mental health challenges, particularly in rural and underserved communities where access to obstetric care may be limited. Licensed midwives and birthing centers help fill important gaps by providing prenatal care, patient education, postpartum support, and ongoing monitoring within a regulated framework that includes standards of practice, accountability, and transfer protocols when higher levels of care are needed. This should not be viewed as a choice between physicians and midwives. Both serve important roles. The strongest maternal healthcare systems are collaborative systems that recognize the contributions of multiple qualified professionals working together to meet the diverse needs of patients and families. As both a clinician and a family member, I strongly support maintaining access to licensed midwifery care in Texas. Families deserve access to safe, regulated, patient-centered care delivered by qualified professionals who respect autonomy, promote informed decision-making, and support healthy outcomes for mothers and babies. Thank you for your time.
Thank you very much, Ms. Lynch. All right, that was all of our public commenters. Thank you all for sharing today.
May I ask some questions? This is Michelle Gold. Sorry, I didn't take my name first. Is this where I could raise something to the next agenda from the public comments?
No, that agenda item is at the end
At the
at
end, okay.
agenda item I.
Okay. Can I make a comment about the public comments in general?
No, that's why we asked that there be no follow-up unless it's to clarify a statement, because otherwise there's a deliberation that hasn't been put on a agenda. So the public doesn't have notice that discussion would take place.
Okay, so I can't ask about like how TDLR and public comments work in general.
Sure, yeah. I mean,
Okay. Yeah, so I just wanted to ask about what did you say, Destiny? It was 174 public comments that we got that were emailed.
Yes.
Okay, and I know that we can't, read those comments. But since they are public comments, how, besides the Open Information Act and like requesting them that way, is there any way that TDLR can, bring those forth to the public? Is there any way that we can get those comments or a link to those comments published on the TDLR website so people can see those?
we can look into the possibility of doing that, but generally to obtain those, you would need to do an open records request.
Mhm. Okay. And then, okay. Yeah, it's also, I also fielded many calls, I feel like in the weeks leading up to this meeting about confusion about how to submit public comments, like what it actually means. I think a lot of people, they just assume when they're going to do a public comment, especially in conjunction with the Midwife Advisory Board meeting, that they will be heard or publicized in some way since they are a public comment. And so I just wanted to make note of that. Just maybe, I don't know if there's a way to like kind of clean up that public comment section on the Midwives Advisory Board Open Meetings website page, just to make it very clear that like these aren't read. There are instructions currently, but I think people still get confused when they go to the website. So I just wanted to point that out, that that's what I have been hearing from the community.
Okay, thank you for that feedback.
Okay, thanks.
This is Michael Nix. I'd like to ask for a clarification on one of the comments. The comment, and I don't remember which commenter it was, but it was on behalf of an organization, and they represented that a board in Colorado had been sued, and I was not clear what the ask was from that comment, because it seemed like there was a discussion of litigation but I'm not sure what the ask was or what the concern was from that specific comment. So just looking for clarification on that.
This is Roxanne Anderson, and that was my comment. May I answer Dr. Nix?
Yes, just briefly, just to make the clarification that he requested, please.
Right. The ask is we would like to not join Colorado in needing to bring litigation to our state agency. There's 4 states right now undergoing litigation from the midwives toward the people who are regulating them for discriminatory or exclusionary practices. And my request is we would really like that to not be Texas. Just saying that happens, we don't want it to happen here.
Thank you.
Does anyone else have any clarifying questions?
Hi, this is Danielle Hurst. I just needed a clarification, and this is from Jamie Hinton's comment. I just need clarification. She made a comment about people, or maybe her community, don't feel comfortable making complaints, or complaints cannot be made. Just needing a clarification. Is she looking for the board to see how it could complaint and just make a transparency how complaints can be made, or what is her ask? Thank you.
I think that I think that particular comment may have been Amanda. As far as people not feeling comfortable making complaints because of ridicule in the community, is that what you're speaking of?
Yes, I think there was a comment made about, yes, complaints being made and no transparency in how to go about that.
I believe that was Amanda Calicut.
Is she still online, or?
It does not. It looks like she jumped off.
Okay, thank you.
Are there any more clarifying questions from the board members? Okay, at this time, we will take a 10-minute break. It's 11:10 a.m., so we will resume for the rest of the agenda at 11:20. All right, we will continue the meeting and Ms. Marshall will take a roll call.
Okay.
It is 11:22.
Thank you. Danielle Hurst,
Present.
Kristen Bowers,
Present.
Gretchen Robinson,
Present.
Jennifer Kelleher,
Present.
thank you. Michelle Gold,
Present.
Melissa Bates,
Present.
Dr. Guillory,
Present.
Dr. Nix,
Present.
and Presiding Officer Destiny Hooper.
Present.
We have a quorum.
All right, we will continue back to the public comment section. If Danielle Hurst would like to ask her clarifying question again, we have Miss Amanda Calicut back.
Hi, this is Danielle Hurst. Thank you, Amanda, for jumping back on. I just needed a clarification. You had talked about there being a better complaint system. And so my ask or my question is, can you please clarify on what that means? A better complaint system, is that just having more access or more information about it? Just clarify on what that means to you. Thank you.
So, in the case of negligence or wrongdoing, a mom who may have lost her child or who went through a traumatic experience is expected to report her midwife to TDLR. TDLR doesn't know about anything that's going on in the community without a mom or someone else reporting that information. And a lot of times the moms don't think that anything has happened to them or that they don't know how to file a complaint, even though it's in the paperwork. I think a lot of people are in this newborn phase or in a grieving phase where they don't understand or can't wrap their mind around that or go figure out how to do that because they are in a position where um, it's just too much. So they're expected to file these complaints where they may not ever be able to. So a lot of it goes under the radar from TDLR. So unless somebody finds out about it or there are investigations done or somebody talks about it on Facebook, there isn't any way for TDLR to know what actually is going on in the community.
Okay, thank you.
Mhm.
Is there any other clarifying questions before we move on? All right, we will move on to agenda item F, staff reports, briefing from the licensing division. I'll call on Charo McCain, license and permit specialist lead.
Hi, good morning, advisory board members. And my name is Chara McCain. I'm a team lead of health professions team working on Midwives program. And I'm here for today to give you the statistics report for this program. And so for the second quarter of 2026, we issued 10 new licenses. 95 licenses were renewed, and 100% of this renewed license were completed online. And the total population for the second quarter fiscal 2026 is 321. And that concludes my report, and I'll be happy to answer any questions that you may have. Thank you.
All right, if there's no questions from the board, we will move. Oh, yes.
I think there was Kristen speaking. I think there was a hand raised from
Jennifer, was that accidental?
Yes, I did have a question. So just for clarification, in the first quarter of 2026, there were a total population of 417 midwives in the state of Texas. And now in the second quarter, that has been reduced, that total number, to 321 midwives in the state of Texas. Is that correct?
Yes, yes, ma'am, because these numbers were reported at the time of renewal.
Okay.
So most of these licenses were at the state of renewal period.
I see. So they had technically expired, but had not completed the renewal process?
Yes.
Gotcha. Okay. Thank you so much for that clarification.
You're welcome. Thank you.
I'm sorry, my hand is up.
Yes, Miss Guillory, go ahead.
Okay. Could you go back to that same slide, please? Just for clarification, it looks like for the year 2025 total, there were 411. And now in 2026, in 2 quarters, you have more than that. Is there an increase in the number of midwives applying or getting licenses? Is that what we're seeing? I don't have a year before then to get the trend.
Oh, 411.
See, that's just the quarter and the second quarter. So you have 2 more quarters.
There was an increase of 6 licensees as of fiscal year 2026. This is the total population as of first quarter 2026 is 417.
I see that. I guess my question is exactly what does the total for 2025 411 mean then? Is that 411 applied throughout the year?
They're the total licensees, active licensees for 2025. And then for the first quarter of 2026, there was an increase of 6 licensees, total population.
Okay. Thank you.
You're welcome. Thank you.
I think
Does
Danielle
any-
has her hand raised.
I'm not seeing the hand raises, so if you have a question, if you want to just state your name and start speaking, because I'm not seeing those on my end. I'm sorry, guys.
Hi, this is Danielle Hurst. I just have a question regarding do we have any statistics on how many weren't renewed as opposed, I guess, our fiscal year 2025 to 2026?
Oh, at the moment, we don't have that report, but we can give you that report once we have the statistics, once we run the report, ma'am.
Okay, thank you.
You're welcome. Thank you.
And this is Steve Bruno, Deputy Executive Director for Licensing and Regulatory Services. Is your question about folks who maybe had an incomplete application or folks who used to be a midwife but maybe stopped and didn't reapply?
It's regarding those that had and no longer are
Okay.
reapplying.
Okay. I think we can find that, we don't we've got data on who used to be, so we don't always know that if people don't reapply, but we can see if we can find some ways to run that. But I wanted to clarify what you were saying because there was an earlier question about was that the number of people who had applied? That was a snapshot, and that's another thing to remember is that these are just snapshots in time. Every day we're getting new applications or new renewals, and so that 411 it's not necessarily the number who applied because you could have folks who apply but maybe have some missing information or need something else, but that 411 was the total, reflected the total population. And so you will see, you know, between, as Charo explained, there's a slight dip at the snapshot when the first quarter, from the first quarter of 26, excuse me, to the second. I hope I didn't make it that worse or more confusing. I was trying to. Okay.
No, you're good. You're good.
Great.
Thank you.
Great. Thank you.
Kristen Bowers here. So just clarifying, the 321 is not an indicator that we are now almost 100 midwives less in Texas at this time that are licensed, or that is what that's stating?
Well, at that time, that's what that data showed. You know, by the time we get to the third quarter, I don't, you know, none of us know what's happened from the time that this report was run to, you know, what happened last week or yesterday or what's coming in today. So again, that's why it's a snapshot. But you are correct. The total population was down when we took that snapshot, if you will, at the end of FY 2026. But again, recall, because of timing in a license term, it's a constantly moving number, if that makes sense.
Right. And just to clarify also, the renewals across the board are always due, I think, is it at the end of February? Is that correct?
Correct.
No, it should be, unless, and please someone help me if I'm mistaken, it should be, there's not a set date. So we intentionally try to avoid things like that so we don't have one compression of you know, a clog of stuff at the end of February or whenever it is. It's always based on when your application's approved. So if I were a brand new applicant, and let's say I got my license today on June 17th, then my expiration date would follow that. Unless I'm mistaken about that. Someone please jump in and tell me.
Yeah.
It Thanks,
So
Charo.
all midwives licensees, all their expirations expires at the end of February,
Oh, excuse me
February
then.
28th.
I get our programs
Yeah.
confused,
All
y'all.
of
Please
them,
forgive
yeah,
me.
all of them expires in February 28th. So at the time these figures or these numbers were taken out from that report, so most of these licensees, midwife licensees, are in a renewal state. That probably most of them are just in the process and not completed it yet. So yeah, that's the reason why it's lower
Well,
than
It
first quarter of 2026.
I guess my
Total
question then would
population.
be that if it was in February that the renewals were all due, wouldn't that, um, considering that the renewals are due in the first quarter, that's why we have the 95 that renewed in the second quarter, because it would have rolled over for TDLR to have time to process all of the many midwives that are renewing. So essentially by the end of the second quarter, which would be presumably 3 months, which is about now, we would be, any of the midwives that were going to renew or
Mhm.
had submitted for renewal would presumably have renewed. I would assume. Otherwise, they would have elapsed at this point beyond their renewal point. Is that an accurate statement?
Yes, after the because the last quarter is February 2026. So some of them have renewed, some of them are renewing like at the end of February or after that. So by the time it's taken, like I said, these numbers were the ones who renewed until February.
And
Okay.
Derek Burkhalter, Assistant General Counsel, I just want to clarify and make sure we all understand that the fiscal year for state government begins in September. And so the first quarter is September, October, November. Second quarter is December, January, February. So we're just seeing the snapshot at that end of February point where a lot of those renewals have not yet been processed yet.
Okay, that
Thanks for
makes
that.
much more sense. Thank you for
That's
clarifying.
Yeah, thanks, Derek. That's a super important point that I always forget to make about the normal months that we all live by and fiscal years that we do government accounting by. And also, I just thank you to Yvonne Lopez in our licensing department. she just chimed in to let me know that we do have data as of the third quarter. And so if I was able to add a column here for third quarter, it would show that the population today is 401. So back to, you know, what we're used to seeing.
That's much better. Yes. I was a little concerned.
Thank you. Yeah. No, I understand that. I understand that. There is not a concern. We do not see a trend in a declining number, if that makes sense. We see a steady population commensurate with the numbers that we're used to seeing in this program.
And also to answer Ms. Christine Bauer's question about if this 321 are the total population. So someone has told me that currently we have a 402 currently licensed as midwife.
Thank you. I appreciate all the clarifications.
Sure. Thank
You're
you all.
welcome. Thank you.
Hi, this is Danielle Hurst. Is there any statistics showing where most of these licenses are coming from? North, South, East, West Texas? Do you have any numbers on that?
We don't have that available for now, and we'll see if we don't have that information, ma'am. I don't. Yeah, we don't have that information.
I'll make a note to see if that's something that we are able to
The
provide.
report.
Michael Strawn, Education and Examination
thanks for-
Director. Yeah, absolutely. Just because I've done reports like this for many of our other programs, it's something that we could do using data for our licensees to be able to put it on a heat map and see where we have representation from. So we would be able to do that, Steve. It's going to take some programming and extraction of data, but
yeah,
it's possible.
Okay. We can work on that, and then we can share the information through our advisory board staff, excuse me, and we can get that to you all.
Thank you so much.
This is Mike Nix. I just wanted to make a comment on this. There was an extensive amount of online comments related to, or written comments related to the support of ongoing midwifery practice in Texas. And based on what sounds like the most recent data, which was given in this specific session, the number of renewed licenses really hasn't had a dip over the last year. So that helps, just makes me think we may be able to address some of those concerns in the comments.
There's any more clarifying questions on the licensing division for Charles McCain, or we will move on to the next item. All right, I will call on Michael Ford-Strawn, the director, to give us an education and examination division report.
Good morning. As introduced, I'm Ford Strawn. I'm the new director of our Education and Examination Division, here to give you our report today. First thing I have on the report is our jurisprudence examinations. As you know, as you heard earlier, this is a licensing program where we do not have our own examination for knowledge and skills. So that's done externally, so we don't, what we normally would report would be very robust as far as pass rates, where people are succeeding, not succeeding, trends, things like that. Within this program, we just have the jurisprudence examinations, so we just have the laws and rules, and what you'll see here is within FY25 to FY26, we're pretty consistent with what we saw in the prior fiscal year. We're on track to meet that same 120 or around that total for jurisprudence examinations. So we remain consistent there. The midwife school curriculum approvals that our division does as well have remained absolutely stagnant and consistent. So we've kept that 2 that we've had here going into FY26. We could scroll down just a little bit further. And we'll get into our updates. So E&E has been really kind of trying to get involved as much as we can within our midwifery program. We have a very talented team lead and group that's been dedicated to this. And recently even brought on a intern who is from Texas State and has really brought some new life into this. So we've been working with our compliance division, our enforcement, field inspections on updating our curriculum review processes, updating the entire program to make make sure that even from the TDLR side, we understand what we're doing, what we're requesting from the public is more clear in that regard. And that even extends over into the form updates. You'll see on here that we've been updating our forms on the website. Some of that was intentional with some of the lawful presence requirements we had as far as collecting social security numbers or FEIN within that process, but also looking to make sure that we have things that are removed that were onerous, that clarifying different areas. At one point in time, we had an entire wall of text with all the list of requirements that you needed to submit to us. It was very difficult to read. Things get lost in there, and that slowed down the process as far as requirements. We'd have to send out an RFI, or request for information, because people missed some of the things that were on that wall of text. So now we've at least stepped that out into a list that's easier to read, easier to digest. So we're trying to make improvements all across the board on how we look at that. And lastly, on this update list, we've been trying to convene a work group. It's been something we've been working really hard on. It's been, we continue to try and do that at this point in time. We hope from the last advisory board into this one, we would have a work group report for you. But it's just been very difficult to align all of our members at this point in time, and our team is still working on that so we can have updates to the midwifery manual and other rule suggestions and processes at that point. I do want to say, that we had the new interns here as well, and we've given them a deadline to have our draft of the midwifery manual working with our teams to us, hopefully no later than end of July. So we are working diligently on those topics at this point in time. And then last, I want to close with the audits. So we just talked a lot about the renewal processes that are happening. Our group also selects midwives and other licensees for CE audit to make sure they've completed their continuing education audits. One of the things that we want to highlight is that if you are selected, you will be notified via email and through letter with your renewal notice, and you'll get the requirements to tell you how to complete that CE requirement. You'll see a link here on the report showing that we have a website where you can submit everything. But I wanted to point out that our audit process does not stop any of the license renewals that you saw. I know that there was the dip in there with 100, and Derek and Charo and Steve helped point that out. But anybody that was selected for that CE audit, we're not holding up that license renewal either. So this was not being an impact for anybody that was renewing during that period. We're checking it afterwards and working with that licensee to make sure they get all their continuing education credit submitted to us. That being said, that concludes my report, and I'm open to any questions you may have.
Hi, Michelle Gold here. First, thank you for your work and your team's work in doing all of that, and also explaining the CE audit process as it is now. I just had a question about the curriculum review part. Is that something that the E&E work group also takes part in? Is that how midwives are included in that process?
Yes, ma'am. Anything that is education related to, we can discuss within that E&E work group. So anything that we can and often do need your all assistance with, we're going to employ your use in that.
So we just need to get that group together. There was a little bit of confusion, I think, on some of the members on how to RSVP and respond. I think the work groups have different methods on how they do that. So again, just like maybe a little bit clarification on how the work groups in general can, RSVP from, we're like really busy during the day. We see an email, we're like, yes, we can do that. And then that's it sometimes.
Yes, ma'am. We'll work on making sure that we can make more availability to you all as well, so we can get this work group taken care of.
Great. Thank you so much.
Yes, ma'am.
Guillory here. Could you tell me what percentage of midwives are audited yearly, or how often?
Yes, ma'am. Michael Strawn, Education Director. So that's a good question. And in reality, it can be anywhere from 10 to 100%. So we were within our system allowed to select any number. I would have to go back. I don't know what they selected for this one, but some of our smaller programs, which I would put y'all in line with, we will typically do a large percentage of that, if not 100% of that renewal, just because that's feasible for us to do so, and pertinent to do to make sure that we're making sure that everybody got all their licensing requirements taken care of. This may be more difficult in programs that have hundreds of thousands of licensees, where a percentage, about 10 to 15% may be more applicable. But our staff, and we actually just hired and fully staffed into that, although we did have somebody promote. So we have now a greater ability to do larger audit samplings as well. So I don't mean to dance around that, but that number does change based on the needs of the programs and the size of the programs.
So the
Kristen
100% was done.
Bowers.
Oh, sorry,
Oh,
Kristen.
that's
Go
it.
ahead.
Kristen Bowers here. I was just going to ask, because yes, you had just said that it could be between 10 to 100%. And that since we are a smaller in comparison to other licensee groups, that there's enough staffing to potentially do 100% audit, like almost all the time, is what I'm hearing correctly. Is that true?
Uh, yes, ma'am. I mean, that would be my desire, especially for the smaller programs, and something I've conveyed over to the manager for that program, and I know he's working on as well, is that we're going to be ramping up and doing even more audits than possible. He's been really engaged in making sure that our auditing process with schools, curriculum, and even individual CE audits are focus for us. And these smaller programs, we are definitely wanting to do 100% across the board. We want to do as much as we can, even in the larger ones as well.
Then I guess my question bears that the efficiency of this. So previously we had already, and many of us still do, we just submit everything because that's what we're used to. We submit all our CEs, we submit all of our stuff every time that we renew. And with the last audit, I think everybody was very surprised when, 100% of people seem to be auditing. And now that you're saying that just because we're a smaller group, that's the plan probably going forward, is just to audit everybody who's renewing, which by all means. I guess the question is, if this is in fact supposed to be more efficient, why are we then potentially auditing on the back end? Wouldn't it then be more efficient to just submit all of our CEs per the norm like we usually have, versus then having to wait? And I know that you're saying it's not affecting licensing, so I'm not, just as far as efficiency, wouldn't it then just be prudent for any renewing midwives at any given time to submit all of their CEs, because we all have them anyway, or we should, um, and submit them all anyway when we're doing the renewal? That way you just get them already in advance, and there doesn't need to be any back end where there's back and forth between, okay, I'm submitting my renewal, I'm probably going to be audited. Okay, now I've waited for the paperwork. Now I am being audited. Now I have to go back online and go ahead and submit that, versus just submitting it when we're submitting our renewal. I feel like maybe that would be a more efficient. I'm open to feedback or like discussion on this, but I guess my ask is, how is the CE audit process, if it is in fact intended to look at 100% of the renewal selection, more efficient than just asking licensee people who are renewing, to submit their CEs up front, and then there's no back and forth. It's just an automatic, they're there and they can be checked at leisure by the
First,
audit board.
first of all, I want to highlight and say, excellent question, and it speaks very much to a lot of the critical thinking I asked our staff to do and look at. And so you highlighted, and one thing you repeated is, how's it more efficient? And I will tell you that in the name of efficiency, it's not more efficient. This was a change made, obviously, before I became director, because y'all went through it last year. And the idea was necessarily that it would be a little bit more of a burden on the department. It should not be, hopefully, more of a burden on the individuals, but I can certainly look at that process. They should be getting selected for audit at the time of their renewal, so they're notified at the same time, so they can upload those documents in that same manner. The issue that was being discussed at that point in time in the past about the impact for the CE audits was that it was a huge burden on the licensing staff, and it was causing a delay in the renewals. So right now our licensing staff is processing, I believe, over like 98% in under 10 days, and that wasn't always the case. And so the CE audit or CE review for license renewals was taking astronomical amount of time, to the point where people's licenses sometimes had a lapse, even if they were renewing on time. And in some of our industries, that was actually causing or potentially cause a loss of employment, because if they didn't hold that license permanently valid through that entire time, it was having a negative impact on them. So it was chosen to do this audit on the back end of everything so that we didn't impact somebody's licensure who had been doing the right thing at that point in time. It is less efficient on the department to be able to do this and more work for us. But certainly, I want to be cognizant of your concerns that we're putting an additional burden on the licensee as well. So I'll take a look at that process. The intent is that when they're renewing, they get that same notice. They're flagged before their renewal notice goes out, so they know to provide that in kind of the same manner, just upload those documents in a different area so that we can work through that without stopping that license renewal. So I hope that answers your question. And I do want to highlight that I think you have an excellent point, but I believe efficiency was not the reason that this decision was made. It was so that we did not have a threat to licensees' renewals due to us being inefficient in that process.
I understand. Thank you for the clarification.
Yes, ma'am.
Michelle Gold here. Have there been any trends or themes that you've seen with the audits of continuing education that we should be aware of?
This is a question that I had just posed to the staff and we had had a conversation on, and this is one of those areas where I'm trying to remember what that was now I'm on the spot. If I recall correctly, because we just did this, there were not any specific trends that we had as far as people were not taking a specific type of curriculum, or if they were submitting fictitious information to us. What we had seen mostly is that our biggest hurdle was people finding their documentation to provide to us was one of the hardest things, and submitting it. They didn't keep all of their records. They often had it, but they just didn't have the records of it. And so that's been the biggest one that I know our staff's brought to me. There was no major concerns about them taking incorrect CE or falsification of records, things like that at this point.
Thank you.
Yes, ma'am.
So I'm Jennifer Kelleher, and I have a question about the audit. Is the audit purely just going through the paperwork and making sure that it aligns with what the documentation on the application renewal, did they collaborate with each other? Or is there ever part of the audit that is actually validating and verifying that all of these CE certificates and hours that are claimed are authentic?
Mhm.
Is that so? Are you saying that 100% of the audits are 100% authenticating submitted CEUs?
So I don't want to lie and say that there's 100% that are being authenticated, especially for this program, because I don't know everything that they're looking at exactly. I'll speak to our process in general terms. So oftentimes, many of the CE providers are approved, or they're something that are already on a list of pre-approvals that we have. We maintain these types of things so that our staff has an easy reference to go back to. If there's something we come across that we've never seen before, an entity that we don't know, our staff is doing diligent work to make sure that that is something that is legitimate, that the curriculum they're providing is meeting the terms of those CE requirements. Because at times we may get something submitted to us and we have no idea, based on the title, the certificate, or anything else that was provided, that it meets the subject matter that our rules allow for continuing education credit to be given. So we're taking that into account, and so we're trying our best to make sure that that's 100%. I won't say that it's a manual process. There could be something in there that's missed, but that is the intent within our review. And we do a lot more within our auditing, within schools, within curriculum. So the team that's working on that are very talented. I mean, they've been through multiple trainings, clear investigation training, So they're really diving into whatever they can across the board, and it's a lot of work, but they are trying to be as diligent as possible, create resources and references as well, so they can be as expedient as possible when reviewing these.
Okay, thank you.
Yes, ma'am.
All right, if there's no more clarifying questions, I will call on Ms. Claudia Enriquez for the customer service manager for the customer service division statistics.
Hi, good morning, board members and TDLR staff. I am the customer service manager for this program. As you can see in our report, the total contacts received in our customer service department for May of FY 2026 were 16, which is a decrease in compared to May of FY 2025. March continues to be our highest volume month for total contacts received in our department, especially so far for FY 2026. That concludes my report, and I'm happy to answer any questions you may have.
This is Guillory. Could you tell me what's the primary reason most people utilize customer service contacts? Is it questions about the licensing or?
Yeah, absolutely. It could be just a license status request, maybe to see if their documents were received, or if it's a new applicant, maybe to see the application process, have questions about it, things like that.
I think I was concerned, do they ever have complaints or something? Do they ever make the initial contact there?
They could, not, it can happen, but we usually do refer that to our online complaint form.
Thank you.
You're welcome.
Kristen Bowers here. Do you find that most of the contacts are coming from midwives or up and coming midwives, or are they more from consumers?
It's mostly from midwives. It's mostly from midwives, checking if their documents were received, or checking on their application or license status.
The Destiny Hooper here. Would it be possible to have a way to see that, like a data that shows who's calling and what they're calling about?
I can certainly see if we're able to get that data for you. We'll have to get that to the board meeting as soon as we can compile that for you. But yeah, it will take us a little bit.
Thank you.
Sure.
If there's no more clarifying questions, I will call on Miss Anna Clark, Program Specialist, to go over the Compliance Division.
Good afternoon, presiding officer and board members. My name is Anna Clark, and I will be giving y'all the Compliance Division staff report today. For current projects, staff, including our General Counsel's office, has been focused on refining the informed choice and disclosure form after our recent work group meeting. Y'all will have more information about that during agenda item G. We are also preparing for our site visit in August with the Association of Texas Midwives. Like Ford said, we are collaborating with them to update the midwifery manual and should have something to present later in the year. We also continue to assist other divisions with questions from licensees. Regarding outreach, we attended a virtual conference held by the NACPM last month. Some of the topics were the growing demand for midwifery across the nation, trauma-informed postpartum care, and clinical research advancements. We also attended, along with our General Counsel's office, the St. David's Midwifery Symposium, focusing on ongoing efforts to streamline hospital transfers. We are excited to attend 2 upcoming conferences in the fall, the Public Health and Midwifery World Conference in September, and the Association of Texas Midwives Conference in November. Please check out our Health Monitor newsletter, which will come out today if it hasn't already. It has a lot of great articles in there about our team's programs. You can find it on our main website or on the midwifery page. If you would like further additions in your inbox, please sign up for email updates. And if you know any events you'd like us to attend, please let me know. That is the end of my report, and I'm available to answer any questions.
Anna, can I jump in? I believe, in response to an earlier question, I believe you may have a heat map. It may
Yes.
be from last year. So what I was going to see, if you don't mind, could you go ahead and share that? And then we can offer to update that with the most current information.
Yes, we do have a,
Thank you.
heat map regarding midwives in Texas. It is from last year, but we will definitely, our staff is working on getting that updated as of today. But I can go ahead and share if, Carmen, if you would stop sharing.
And this is in response to the earlier question regarding the spread demographically, geographically, where midwives are located across the state.
Yes, so this is, can everybody see this? Okay, perfect, thank you. So if you will see, the darkest blues that we have in Texas are the counties that have the most midwives. All of the counties that are white have none. Yeah, and we are working on getting not only the most updated heat map for Texas, but also a heat map that shows the midwifery care deserts in Texas as well. So the counties that don't have hospitals with labor and delivery units, and then combine those two and seeing what those look like.
And Kristen Bowers,
Hi.
just for clarification, this is looking at licensed midwives in comparison to other states. Is that correct? They're
This is
licensed midwives as well.
This is just licensed midwives in Texas. It is not in regard, well, the one on the very bottom has the licensed midwives in other states, but
Okay.
the Texas one is just for us, yes.
Okay. And so it's not inclusive of a certified nurse midwife in other states. It's looking at just their licensed midwives through their state.
Yes,
Just to make sure we
just
have
through
the
us.
accurate. Okay,
Yes, ma'am.
perfect. Well, that's good to see that we're leading the way.
Yes, ma'am.
And Ms. Clark Guillory, did you say you're going to be looking at the maternal deserts and then see where and overlay it on the map to see where they are located? Okay.
Yes, ma'am. It's
Thank you.
mostly from what I've seen is West Texas has the most deserts for hospital care, labor and delivery care units. But yes, we will definitely search for those.
The dark spots right now looks like it's in very large places.
Yes, ma'am. So we have the triangle here, Dallas, Fort Worth,
Mhm.
Austin, San Antonio area, and the Houston area, as well as El Paso here.
Michelle Gold here. I have a question about, this is all the, I had asked before, but I'm gonna ask here again if we can do this, but this is all the counties that when like we license midwives, when we sign up, we like put one county, right? Is there
Yes,
any
ma'am.
way when we sign up to put the counties that we serve? Because
Ooh.
probably like this, up in the panhandle, I bet those midwives go to more than one county. I know I certainly do. And so I think that would give us a bigger description of how licensed midwives are covering those maternity care deserts, even if they're in the next county over.
That's true. We could have that information, but it would be very hard to capture. We would have to get that information from every single one of our midwives to see which counties they work in.
Could that be a part of license renewal or initial application? Like
That would
here's
be
your
up to our
address, here's your
licensing
county.
division.
Okay.
Well, this is Steve Bruno, Deputy Executive Director. It's a very interesting question and a very good point you make in that this data shows the address that an applicant has provided us. It does not show, of course, the license authorizes you to work anywhere, right? So I think that's a really important point. And we do want to strike a balance between the questions that we ask and what we're required to ask by law, because we don't want to stray too far into what we don't need. It also becomes a data collection and data management issue. But I understand what you're saying, and we will look into seeing what we may be able to do to get that information. And it may come down to some self-reporting and some voluntary sharing of information, because you know, I think it's likely to assume that if someone in one of these white areas was called by you know, that you would go and provide service there. And I think that's what you're trying to get at is
Right, right.
we know where the licensees are physically located, but that doesn't necessarily reflect the coverage of service.
Maybe it's something that like a professional organization could send out a survey, like ATM. They could send out a
Yeah.
survey to their midwives and
Yeah.
get that, and then they could provide that to you guys too.
Sure, sure.
Are there any other questions for me?
Jennifer Kelleher here.
Yes,
In
ma'am.
addition to that, is this form available to everyone at any time? I know that I get a lot of inquiries about new midwives looking for areas that could benefit from midwifery care. And I have not actually seen this particular layout before. Is this available somewhere public? That's
Not
easily
currently,
obtainable?
no, ma'am, but I can look into getting it added to our website. Yes.
Okay.
I
Great,
know
great,
that
thank
you can download an Excel report from our website on who is in what county, but not exactly a heat map like we're showing here.
Sure. Okay, thank you.
Yes, ma'am.
Thanks, Anna. I wanted to add on that, yes, I was just about to make that point that those download files are available and those are updated on a regular basis.
If there's no more clarifying questions for this section, we will move on to Field Inspection Division. I'll call on Lindsay Wren, Central Region Manager.
Good afternoon, I'm Lindsay Wren. I'm not the Central Region Manager. I'm one of the program specialists for field inspections, and I'll be given the field inspection staff report. For midwifery education courses, Field Inspections has completed one inspection in fiscal year 26, and that inspection was conducted in the first quarter. And we will be assisting with the upcoming site visit for the Association of Texas Midwives and Midwifery course coming up.
This is Guillory. It's a stupid question, but when you do a field inspection of the courses, do you go to the courses or what do you do exactly for that?
That's a good question.
This is Anna Clark, TDLR.
Yeah.
So I attended the last site visit. Lindsay unfortunately wasn't able to attend. I think she had a conflict. But she will be attending the one in Decatur for the Association of Texas Midwives. What we do is we go to the site. We will sit in one or two of their classes. We will look at their their student files to make sure all of the information that is required in there is in there. We will also interview a couple of students, just asking various questions about their time taking the course, and we will talk to the director as well.
All right, thank you so much. Next, we will call on the Enforcement Division. Shauna Al Mashouk, Prosecutor.
Good afternoon, board members. My name is Shauna Almashuk. I am a prosecutor for the Enforcement Division, and I'll be presenting the report for you today and cover the key statistics and a case highlight. At the very top is the division's performance measures. Note that the cases that have been closed with disciplinary action has decreased significantly from last year. In the next section, which is the criminal history, there was only one case open due to criminal history and does not appear that it resulted in any adverse action. And then at the bottom of that page, it shows the source of complaints. It is similar to last year, with all of the complaints coming from the consumer. The top of the next page puts that into a pie graph for you based on the cases that were opened from those complaints received. In the middle of the page, you will see the orders issued. This time there was one agreed order, a cease and desist order, and 2 emergency orders. And at the bottom, you can see that there are no licenses with disciplinary action during this period. In the top of the next page shows 12 cases closed without disciplinary action with insufficient evidence leading the rationale. And then in the middle of that page, the alleged violations at opening, you see that there was at least one complaint in every category. And as a reminder, this was only the complaint that was made. It's not necessarily an open case. And below that are the cases that resulted in disciplinary action, which corresponds with the agreed orders we discussed above. And then finally, at the top of the next page, I've added the case highlight for you as an example of complaint cases that were resolved by department staff for your review. Also, as a reminder, we are still accepting applications for subject matter experts for midwives. So the application can be found on the TDLR website. We currently have 4 experts, but we could always use more. That concludes my report. And I just wanted to say that I haven't forgotten about the questions that y'all asked from January last time. So I do want to take a moment to discuss those real quick. So one of the questions, I believe there were 6. One of those were, can we identify the priority 1 midwife cases and the length of time to closing in the September 25 through December 25 period as compared to the September 24 to the September 24 to December 24 period. Unfortunately, we're not able to pull that data, but priority 1 cases are generally worked first due to the requirements of the Sunset Commission. The second question I have is it possible to identify the priority of the 2 cases that were mentioned in the last report for each of the fiscal years that were in that report? And so when the cases are reviewed to be added to the report, the priority isn't included. So it wasn't something that was looked at that time. And then the third question I have is for midwives, would it be possible to include in the stats to identify priority cases? So our advisory board reports are standardized for all the TDLR programs, and we're unable to provide additional information without significant changes to the reports as a whole. And then another question was, is it possible to run a report on the open cases based on priority? So unfortunately, we are not able to disclose any information about open cases due to the confidentiality of health programs that's set forth in Chapter 51 of the Occupations Code. So we just aren't able to discuss that. The fifth question I have is, do you have the ability to break down the consumer type? Because we don't collect that information, in consumer type, what I recall, the question was being about like the client, a hospital, the public, or another midwife. Because we don't collect that information, we wouldn't be able to provide that at all. And then the last question I have from last time is the complaint process the same now at TDLR as it was when the program moved over from its previous agency? So the midwifery program moved to TDLR, I think about 9 years ago, or we're coming up on 9 years. And so we don't have any information about the previous structure of the complaint process. But when midwifery came to TDLR, we aligned it with the complaint process that already existed at TDLR for the other programs. I wanted to let y'all know that I'm available to answer any questions that you might have regarding the report, but there is another presentation after mine about the enforcement process.
This is Mike Nix. I am able to describe a little, at least a little comparison of what it was like before these programs moved over, because I was on the previous board and I'm on the current board, advisory board now. I can say one of the major differences is there is, I do not, the subcommittees that we have of members of the boards do not have direct input into the evaluation of cases that go through any longer with the TDLR, where we used to do it with the DSHS. And I believe that is why you're saying we have member experts that you're asking for applications for, that do those pieces instead, rather than the members of the Midwife Advisory Board.
That's correct. This is Shauna Almashuk. That's correct. Yes.
I do want to
This
make a
is
clarification, because I think that some of the public comments and concerns that I've seen were about ongoing practicing whenever there could be a danger to ongoing health of women in Texas under under providers that may have and may have provided poor care. And one of the ways that we are able to track or identify or see how well we are doing ourselves is to set up those priorities and track those priorities within the systems. So my ask would be that though, even though you may not be able to disclose those, that there be some way to reassure or help or even initially to evaluate how rapidly those high priority cases, what is a prioritization, and how efficiently those are being addressed, so that ongoing health concerns are as short limited a time as possible. In other organizations, there is an immediate cessation of licensure, and you stop practicing until you are proven to be able to practice afterwards in certain circumstances. And I don't know if that necessarily exists within this practice. And I think that is another one of the concerns that I heard expressed that I really appreciated, was the governing. We must be able to govern your own and monitor your own healthcare outcomes in order to be able to improve and provide efficient and safe care.
This is Shauna Almashuk. Thank you very much for that, Dr. Nix. I know that John Medlock is going to talk a little bit about that during the complaint process, I believe, in his presentation in just a moment. But I will say that we have to operate based on how the legislature has set up our processes. And my understanding is that we can't take someone's license away arbitrarily without there actually being proof. So just wanted to offer that bit of information as well.
So this is Jennifer Kelleher. I'm looking at the bottom of page 1, where it talks about complaints received by the source. Consumer is the first line. The second line is departmental with a number of 4. Can you tell me what that means? What does complaints received by departmental mean?
This is Shauna Almashuk. So yes, that could mean multiple things. Sometimes we receive news articles about something, for example, an arrest. We receive information that way. Sometimes if someone is arrested, we get notified by DPS. So that would be like an internal. Sometimes compliance will learn of something, and so they will inform enforcement. So there's multiple ways that we could get it. Or for example, in an inspection, if there was something that they discovered during an inspection, that would be an internal complaint.
And then my second question is, the term priority one potentially implicates that there might be a term called priority two. Is that a
Yes.
case? Is that the case?
Yes.
Is there a defined glossary, if you will, about what qualifies as priority one versus another level?
I believe that we do have like a one pager or something that we could provide you with. I don't have access to it at this very moment, but it is the directive from the Sunset Commission that we are to prioritize cases, and there's direction on that, and I will make sure to get that to you guys.
Thank you so much.
Yes, ma'am.
This is Guillory. So I am clear, I'm looking at the different options that people have in terms of complaints. And my question is, where do you, if there's a complaint about an infant's death, where does that fall in?
I'm
I don't see anything about that kind of measurement or checks here. So
right.
I'm looking through the whole thing. I was just wondering, where does that fall in?
This is Shauna Almashuk, and that's a very good question. So I think that at at the outset, I'm not sure how our intake department categorizes an infant death. It could be unprofessional conduct, or it could be malpractice. Um, I'm not sure how they identify that. I know that on the cases where, if it is identified that there was some malpractice, it would fall under that type of category or professional misconduct. I believe that, um, and if there is no, even if there is an infant death and it's determined that there was no wrongdoing by the midwife, then it may still get logged under. May I see page 2, please? Actually, I'm lying. Page 3. Because alleged violation at opening, it might stay the same. Thank you for zooming in. So it would fall under insufficient evidence.
Okay.
If it were an infant death and it was determined that there was no fault by the midwife, it would fall under insufficient evidence.
Thank you.
Yes, ma'am.
Hi, this is Danielle Hurst. I have a question specifically on this page where it says complaint withdrawn. And it says there's 72. What constitutes a complaint withdrawn? And to follow that, if a complaint is submitted, does the midwife who's, alleged whatever this complaint is, do they get a copy or do they get notification about the complaint, which then may cause a person then to withdraw a complaint? Because I see that there is, concern that people don't complain because of, maybe being scared or nervous that, they're going to know about it and therefore it causes them to do that.
I believe
Derek Burkhalter, Assistant General Counsel. So next up on the agenda, we have our Chief Prosecutor, John Medlock, who's going to give a detailed presentation about the process. I think it might be useful to save process questions until that presentation so he can kind of address them head on, if that's okay.
Okay, thank you.
Gretchen Robinson, I have a question. It is another page down. It's it was the no go back, I'm sorry, go back up. It was the 2 lines where it said complaints from consumer, complaints from TDLR, right? Where is it at? What page was it? It was at the
This is
bottom of one of the pages. There we go. So consumer, and I can see I'm only looking at the MID line. So consumer complaints and then departmental complaint. How does that work? How does that come about? If complaints are supposed to come in from consumer, somebody who's been there, who was a part of that event, maybe in a midwife who, you know, assisted at that birth, or a family member of the birthing family, under what circumstances would department bring about a complaint against a midwife? I'm just trying to understand.
This is Shauna Almashuk. I really appreciate that question. I think that this answer to this question is in John Medlock's presentation immediately
For the
after.
next one. Okay.
Yes, ma'am.
Okay.
But it is a valid question, and I'm glad that you asked it.
And I don't want to step on what John's going to present. This is Steve Bruno, Deputy Executive Director. If I can, well, okay, I'm sorry. I don't want to confuse things. I'll let John speak to it, but let me speak to our other programs, just not just midwives, across the board. We do rely on consumers first to file complaints. Also, we have, for example, in many of our programs, we have inspection requirements, right? And so it could be the case that somebody from our inspections team or our field division, our field inspections division is out, and they see something, and we've categorized and prioritized things they might see that's a serious violation, and we want to send that directly to the enforcement division to get on. That would be a department complaint. Another case might be, you know, of course, like all of us, we monitor the news, and we may see a news story from somewhere across the state of something that's of concern that may prompt a staff member to file the complaint in that case. So there's a few different circumstances, and I'll let John to get into the details. I just wanted to jump in with that.
Thank you. I will call on John Medlock, Chief Prosecutor, to do the process for complaint cases.
All right. I should be about to share a PowerPoint for you all. Let me know if y'all see that. Okay. Good, I guess now afternoon. My name is John Medlock. I'm the Chief Prosecutor here at TDLR. I've been with the agency for 13 years and in this role for almost 6. I'm going to give you guys an overview of the enforcement division process, kind of how we handle cases, and try to hopefully answer some of the questions that you kind of already posed already. But just a little bit about TDLR and functional alignment in case you are unfamiliar. TDLR has a licensing and regulatory services side. These are kind of our customer service licensing, the people you heard speak about their divisions earlier today. We are underneath our Deputy Executive Director, Mr. Steve Bruno here, who's in charge of licensing and regulatory services. For the enforcement side, we have a Director of Enforcement, and then we have 4 sections within the division of enforcement. We have our intake section, which I'll talk about, our investigation section, the prosecution section, which is divided kind of into between 2 managers, myself, and I'm in charge of all the attorneys. And then we have a prosecution legal assistant manager who is in charge of all of our prosecution legal assistants and our admins that support the functions that we do here in the enforcement division. Now, just a little bit about the agency. 41 programs that we regulate, so that's a lot of things that we do. So what we typically do is we break them into groupings. We have 7 different sections of programs that we kind of like fit things into. We try to take like programs and put them with like programs. Building, mechanical, beauty and wellness, transportation, health related. This is where the midwife program fits into our health related programs. We have some inspection, consumer financial services, and criminal history group as well. As you can see, between individual and licensees. It's over almost 800,000 licensees. That with when you add in companies and other licenses associated with this, we're well over 1 million licensees in the state of Texas. Over 200 different license types, performing nearly 300,000 inspections. And currently, at the end of this last fiscal year, as you saw, there were 411 licensed midwives. In terms of some things that the prosecution section has done, this just tells you the volume of work that we do here. We opened at the end by all of fiscal year 25, nearly 13,000 cases, closing nearly as many. Now, those are cases that we opened. Those aren't complaints that we received, because the number of complaints we received was actually close to 30,000. And this is, of course, all of our programs. We nearly had 1,650 orders signed, assessing almost $5 million in penalties, collecting nearly $2 million. The thing I'm most proud of is in one of the things that I've asked my prosecutors to do is not necessarily just always seek a solution that results in a penalty or a sanction, but in the situations where it is appropriate and it is right, to try to seek restitution for those complainants, to put that money back into those people's pockets. And last year we did a little bit over $800,000 in restitution to complainants. Now, kind of what we want to talk about here is complaint. We're going to focus mainly on complaint based cases. And what I mean by complaint based cases, as you saw that in that line item, there was consumer and departmental cases. Consumer is just kind of a generic term that we put out there just for categorization purposes. Essentially, what we mean by that is if a outside member of the public, no matter who they are in your particular program, whether it's someone that was utilizing the service of the midwife themselves, someone that was tangential to the service, or just somebody outside of all of that, if they file a complaint, that's going to refer and fall into that category of consumer complaint. If it's somebody within the department that either received information from an outside source, or saw a news story, or maybe some kind of agency referral, that'll be categorized in that departmental complaint type of a case. So, talking about the life cycle of these consumer cases. So essentially, the consumer will file that complaint with TDLR. We can get those in numerous different ways. The vast majority of the complaints come through our online portal. Our online portal is available. It will ask you several questions, gives you the ability to type a narrative, and it also gives you the ability to attach documents if need be. We also do receive them by mail. We still get fax and occasionally phone calls as well. So once that comes into the intake division, their job is to review whether or not a complaint has jurisdiction. And what I mean by that is essentially we kind of ask ourselves two questions at this stage. One, is it a program that TDLR regulates? And with 41 programs, it's quite a bit of stuff that we do. But at the same time, too, the secondary question is, if it is a program that we regulate, is what is being alleged something that we can do something about? And that kind of falls into that question of, y'all were asking about, where does an infant death fall into? So what we have done in our system is we take all the statutes and the rules and we kind of like shorten them for our staff, so that when they're reviewing that complaint that comes in, if they can kind of figure out what they're trying to allege, because obviously they're not using the statutory or the rule language in their complaints, they're just using everyday English to write out what they think happened, or what they think a violation is. So we will try to take that and put it into a small and brief kind of category, so that we can kind of track what it is that's being alleged. So essentially they'll ask those two questions. Is it a program that we regulate? If it's yes, then we move on. Is what they're being complained about something that we can do something about? Now, kind of an example is let's say that somebody filed a complaint because they had a plumber come to their house and they said that the plumber did something bad. That's not something that we regulate. We would not open up that complaint into a case. If it's something like an air conditioning, which we do regulate, and they're saying that the system doesn't work, that's something we can do something about. A situation where they might say, hey, it's an air conditioning complaint. My neighbor down the street got an air conditioning. We have the same house, same setup, and it cost them $10,000. I got the exact same system from the same company 2 weeks later. Our houses are situated the exact same. Everything about everything is the exact same, but it costs me $12,000. Now they're complaining about the price of the system. And in that particular program, that is not something that we regulate. We don't regulate price in that program. And so we would not open up that case. Same thing here. If one person utilized the services of a midwife and they got charged a certain fee, and then another person utilized the services of that exact same midwife, and they're saying, well, they charged my friend, 10,000, they charged me 12. That's not fair. We don't regulate price. We're not opening up that complaint into a case. So that's kind of that first kind of line of looking at what we do here. Once that happens, our intake staff will then assign that case to an investigator, and then that investigator will conduct that investigation. And I've got a slide about that here in a second. And then ultimately, that case will move on over to the prosecutor and an LA to determine the outcome of that case. So the investigation steps. So typically what happens is once the case gets assigned to an investigator, the investigator will contact the parties. They're going to ask the who, what, when, where, how, why questions of those parties. We want to find out all the information that we can. What's the story behind the complaint? What's the respondent, as we call them, their version of the event? Does it match up? Are there additional people that we might need to talk to? What kind of evidence that we need to collect? Sometimes it's physical in terms of like maybe patient records, maybe photographs, maybe some digital evidence in terms of email or just photographs that are digital. And then testimonial in the terms of we want to get the complainant side of the story, what they think happened. We want to get the respondent side of the story, what they think happened. Any other relevant people or witnesses that we might need to talk to. We want to get how they're involved in the case and what information they might have to provide that kind of furthers the story a little bit. Many times in many of our programs, we don't need to refer a case to an expert because maybe we're talking about simplistic violations, whether you did something or had something that was required or not. In many cases, especially in this program, we do require an expert because there are a lot of times standard of care issues that come about during the course of the case. And our investigators are not subject matter experts in the standard of care of midwifery. So that's why we do rely on those outside experts to review those files, to tell us whether or not a particular standard in y'all's industry has been violated or whether it has not been violated. Like just because somebody's alleging something that they think went wrong doesn't mean that the care that was provided actually violated that standard of care. But that's why we need that expert to tell us that. Ultimately, at the end of the day, the investigators will draft an investigative report. Basically, it's kind of just the facts of what happened, what they found in terms of what people said, what people gave us. Here's the location of that evidence for us to take a look at. All those kinds of details were put in there. They're not making any judgments. They're not making any like determinations about whether something was or was not violated. They're just saying this was the allegations. These were the evidence that I found that either backs or does not back up those allegations. It's on for the prosecutor to decide. Occasionally, there might be a need for some supplemental investigation because maybe once we get to the prosecutor side of things, we review something and see, hey, maybe we should have asked this question or maybe we should have looked to see if we have that information. And so sometimes we will send a case back for a very specific reason to try to identify those very specific issues that the prosecutors identified that needed that additional investigation. What kind of options? Once the case comes over to the prosecution side, it's going to typically end in one of three ways: a warning, a closing, or a notice of alleged violation, or NOAV as we call them. So a closing letter, we will send it for a few different reasons. One, we might send it because there's just no legal sufficiency to move the case forward. Just because somebody complains on someone and it's enough evidence or it's enough information to get the case open, through the course of the investigation and the review of the prosecutor, we just determine determined that there is no legal sufficiency to move the case forward. And so we will close the case as being not legally sufficient. Occasionally during the course of the case, the respondent will make some sort of corrections or some restitution, and that will satisfy the complainant, whatever. To answer a question for maybe some kind of accrediting
This
board. If you've
meeting is
ever
being
been issued a
transcribed and
disciplinary
summarized.
action and you have a warning letter, it's not a disciplinary action in TDLR's eyes. So you could safely answer that question as no, you don't have any disciplinary action if you don't have any additional things. And then finally, we can issue a notice of alleged violation. We'll talk about the enforcement plan here in a second. Go ahead and either fine or sanction, or a combination of the two, someone for some action that they did that we view has risen to the level of a violation. Now, with a notice of alleged violations, this is where we believe that the evidence is sufficient to support the allegations that either a program rule or statute has been violated. Now, what does that mean? So if you think about in the continuum of levels of proof, to be convicted in the criminal level, which is, we work in the administrative realm, but just to kind of give you the example, to be convicted in the criminal level, it has to be beyond all reasonable doubt, which I always akin to like 99.999 repeating % certainty that the person did commit that crime. There is clear and convincing evidence, which is about 75%. We're 75% sure that we operate on a preponderance of the evidence standard, which is about 50.1 or 51%. So more likely than not, the evidence shows that a violation occurred. Now, the result of an NOAV can range from, like I said, administrative penalty, which is money, sanction, which is something against the license to prevent you from working possibly, or a combination of both, depending on the severity of the allegations. Now, each of these penalties and sanctions do follow our enforcement plan. Each one of our programs has their own unique set of enforcement plans, and we break them into classifications. So there would be Class A, B, C, and D. Class A being our least severe, Class D being our most severe kind of violations. And the range of penalties and sanctions kind of increase throughout those ranges. We work on those in conjunction with the work groups of the particular advisory boards. Occasionally, when statutes and get updated or rules get updated, we will also modify those. We work with the work group on that to say, hey, maybe we need to make some changes. Maybe we need some new legislation came in, some additions. So we will get with that work group on those changes or modifications, and ultimately get that buy-in, take it to the entire board as well, and then get that sign off. And then ultimately our commission on licensing and regulation will approve and adopt us to use those. Now,
I'm sorry, John. I'm sorry, Derek Burkhalter, Assistant General Counsel. We just got word that the YouTube feed went down.
Okay.
Oh, okay. It should be back now. I just wanted to make sure that this was all available to the public.
Okay. No, I understand. Do we know when it?
I got word, I think it was about maybe when you started this slide.
This slide particular?
I believe so.
You know what? I'll just back up just one slide, just to be on the safe side. How about that?
Okay, good idea. Thank you.
Okay. So sorry if it sounds redundant, but I'll go through this again just so folks out there in the public can hear this. So decisions that are available to the prosecutor, ultimately when the case comes to our desk, we have kind of three different options. Closing letters are when we determine that the case does not have legal sufficiency to move forward. So we will send that closing letter out. Occasionally restitution or some kind of a correction might have been made. That's where the respondent will, say, hey, I'll refund you your money. I'll make this correction or this modification. And we'll usually close those kind of as informally resolved. And then eventually, again, I think there was a question about this as well. What is a complaint withdrawn? Sometimes during the course of intake through the investigation all the way to the prosecutor, the complainant has either worked something out with the respondent or maybe just decided to not move forward with the case for whatever reason. And they will send us notification through email, sometimes phone call, that they just don't want to pursue it and they would like to withdraw that complaint. So we will take that. We will go ahead and close down that case. Again, all these determinations will get sent out. We typically email these out, mail if we don't have an email out to those folks that are involved, both the complainant and the respondent. The next level is the warning letter. Usually there's been some sort of violation, but again, some corrections or some modifications have been made towards remedying that violation. They're typically for the lesser violations. I'll get into that, what that means here in a little bit. But ultimately, at the end of the day, we will send out a letter saying that, hey, we're going to issue this warning for what we consider to be this violation of this warning or for this rule or statute. But because you did make those corrections or modifications, we're not going to pursue the case further. Important to note is warning letters are not disciplinary actions. And so if you ever have to answer a question about have you ever had a disciplinary action against you from TDLR and you've received one of these, the answer to that is you can answer no, because warning letters are not disciplinary actions. And then finally, if we have determined that there has been a violation of either a law or rule in a particular program, we will issue what we call a notice of alleged violation. And we look to our enforcement plan to determine the level of penalty or sanction, and I'll get into that in a little bit. So that is kind of the type of decisions that we can make here. On the notice of alleged violation, this is when we have determined that there is sufficient evidence to support an allegation that there's been a violation of a law or rule within a particular program. Now, what do I mean by sufficient? So if you think about a continuum, like if criminal law, and again, this is not criminal law, we're administrative, but if criminal law, if you have to convict someone by beyond all reasonable doubt, I usually consider that about 99.99%. There's another standard, usually in civil cases, that's clear and convincing evidence. That's about 75% proof needed. Again, we're not there. We're on what we call a preponderance of the evidence standard. That basically is about 50.1 or 51%, or it's more likely than not that what is being alleged, that we do have the evidence to show that that violation did occur. Now, again, the NOAV, when we send it out, it could just issue sometimes administrative penalties, which is money, administrative sanction, which is something against the license, or a combination of both, depending on the severity. Each program has its own enforcement plan with a penalty matrix built in, and these penalty matrices will be broken down into classifications like Class A, B, C, and D, with Class A being the least severe, Class D being the most severe. And as you move through the classes, the range of penalties and sanctions do increase. Now, the way that we create those is we take the laws and the rules from each program and kind of break them down into some plain talk kind of versions of what it is. We do publish it on our website, but the way we typically do it is we'll take a first draft at it. We work with the work group of the board to kind of help us develop this. And then once we get that sign off and buy on, we take it to the full advisory board for their adoption and approval, ultimately being approved by our Commission on Licensing and Regulation. Whenever statutes change or rules get changed, we do modify these things and change these things, or even as industry trends change. Sometimes things become more severe, some things become less severe, and we will make those changes and modifications to those penalty matrices with your consultation and ultimately approval. So if you do receive a notice of alleged violation, they typically result in one of three types of orders, either agreed, default, or commission. So what do I mean by an agreed order? So when we send out a notice of alleged violation, you will see two usually penalty amounts, and depending if it's severe enough, two levels of sanctions. You have a hearing penalty, which is the full amount of the sanction, but then we also discount all of our notice of alleged violations by 75%. So let's say we issued a penalty for $1,000. You'll see that the hearing penalty is $1,000 because that's what the full sanction is. But to encourage settlement, we will discount it to $750. On the back page of every one of our notice of alleged violations, there is a settlement agreement which you could just sign and send in. However, prosecutors do have the discretion to reduce penalties up to 50% of the full penalty. So if you call in and say, hey, yes, I did do this thing, but I just can't afford the 75%, can we do anything else? We do have that discretion to lower that penalty to 50%. But ultimately, it becomes an agreement of the two parties. We get those agreements signed, and then that will be reduced to an agreed order that is signed by our executive director. A default order comes into play when we do not hear anything back from a respondent. So we will issue that notice, and that respondent has 20 days, but we usually give them 25 because of we send these out by certified mail, to respond to us to say, hey, we either agree or don't disagree about this notice of alleged violation. If we do not hear anything within that 25-day period, we will then issue what we call a notice of default, and we give them an additional 15 days to respond to that. Occasionally, we will get some people to respond to that, and we can maybe move that case from the default track into the agreed order track. But if we don't hear anything from the person on that, then we just go ahead and move the person into the default order track. The important thing to note is if you do receive a default order, you will not be getting the benefit of that 75% discount. It will be for the full amount. We offer that 75% to encourage settlement, to encourage people to talk with us and engage with us in the process. Finally, commission orders. So if you receive a notice of alleged violation and you just disagree with the interpretation by the department, you have the absolute right to request a hearing before the State Office of Administrative Hearings. They are a completely independent body, state agency, that is, here's all of our administrative cases. We will get a hearing essentially scheduled. You have right to an attorney. You have the right to represent yourself, however you choose to engage in that process. We will make the presentation, and it's much like a regular trial that you will see in like a civil court. Difference is everything we do now is via Zoom. There is no right to a jury, and the administrative law judge will hear openings statements from both sides. The department has the burden, so we will present our side first, present whatever evidence we have, either through documents, testimonial evidence, witnesses. Other side has the right to cross-examine all those, contest all that evidence. They have the right to bring in their own witnesses, bring in their own evidence, all that kind of good stuff. We'll have closing arguments. Most of the time, they are verbal. Occasionally, depending on the complexity of the case, they might be written closing arguments. Another important thing to remember is at the conclusion of that hearing, the ALJ will not be making a decision right then and there. They will take it under advisement. They have up to about 60 days to write or draft what they call a proposal for decision. Essentially, it's not like a final order. It's basically like, based on the testimony and the evidence and the documents I heard, this is what I think should happen. And there are about three things that they will do. They will say, hey, state, we think you carried your burden and the amount of penalty or sanction is appropriate, and we're going to go forth with that. They can say, state, we think you carried your burden. However, we think that the penalty and or sanction is a little bit high, so we're going to recommend reducing that. Or they can say, state, we don't think you carried your burden at all, and essentially the other side wins. Ultimately, what happens from that is that PFD will then get placed on a commission docket. I believe our next commission meeting is in July, so you will see some of those. We give about a 5-minute presentation. The other side has the ability to make a presentation to try to convince our commission one way or who should essentially win a day, whether we should be adopting that PFD or the proposal for decision, or whether or not they should be overturning it for some reason. You heard a little bit about cease and desist orders. That's another thing that we can do, especially we use these a lot in unlicensed activity. We also use them a lot in our massage program as well, especially if we had human trafficking or prostitution type cases. The emergency order is a special authority that's been granted to the executive director to shut down unsafe equipment, facilities, or to revoke license. It works on an expedited time frame. To get into SOA, we're actually required to have a hearing if we do issue one of these emergency orders. And then ultimately, there's the ability of injunctive relief. That's if we have somebody that's a really bad actor that just has had multiple orders against them, just continues to violate our laws and rules. We have the ability to go to the Attorney General's office to essentially take them into a district court and see if we can get them to be enjoined from continuously to perform those activities. But with that, I will stop sharing, because if you guys have any questions, I will be happy to answer them.
Kristen Bowers here. I do have a question on the warning letters. We it's been reported, at least by someone in the community, that they had received an alleged violation, presumably in a warning letter, but that it was unlisted what the warning was actually for. Would that then qualify as a case closed, or would it be in fact a warning letter if there was no listed alleged violation or presumed violation, however we're wording that?
Right. Without seeing it and without knowing the full details of it, typically it will state that this is a warning or this is a closure of the case. So it depends on how it was listed. We typically have I don't want to say a standard template, but we typically have a standard form in which we write the letters. Sometimes we might write a closing letter that gives a little bit more information that might look in terms of a warning letter, because it's saying that, hey, we think you did some of these things, but because it may be more of an informal resolution kind of a situation. So really the crux of it is the top will say either closing or kind of a warning. So that's kind of how you know which category it falls into.
And all warning letters would then state what the alleged violation was. Is that correct?
They should. Yes, they should.
This is Jennifer Kelleher, and I actually have several questions. One of them, is there a requirement throughout your investigation? Is there a requirement tier or leg of an investigation process that is to involve an expert witness that is actually a licensed midwife in good standing?
So good question. Yes, because ultimately at the end of the day, if we're going to take a case into the state office of administrative hearings, the credibility of that expert witness is paramount. So we are going to make sure that we do several things. We do conflicts checks at the beginning, and this goes for all of our experts. So if we're going to involve a expert, we will first make sure that that expert does not have a conflict of interest with the person that they are going to be records or whatever they're going to be reviewing. We're going to make sure that they have that they don't have that conflict of interest, because shocking, competitors sometimes don't like each other and might want to find things where they're not. So we want to make sure that they're conflict free. And then secondarily, if they themselves have a lot of history, we want to probably make sure that we don't include them, because again, their credibility is always paramount when we were going into the state office of administrative hearings. So to answer your question directly, yes, we do make sure that the people we're using are licensed within the program that they're seeking to provide an expert opinion on, because I'm pretty sure y'all don't want an electrician providing expert opinion in your programs. So yeah, we will make sure that we have a midwife that is licensed by TDLR reviewing those records. That is also in good standing.
And then another question is, what kind of is there a requirement for an investigator to be familiar with midwifery laws, midwifery rules, like a thorough understanding, comprehension? What is the process for these investigators to be able to accurately investigate an industry that isn't super mainstream?
No, yeah, and we have lots of programs that are that fall kind of in that same category. So our investigators do receive training, both from internal and external sources, either in the programs that they regulate or just in general investigative techniques, right? So a lot of our folks are former law enforcement, so they've received their training from those particular sources. So we continuously, matter of fact, we're actually having a week-long training next week for the entire division, and part of that is on investigative techniques. So we do seek out people, especially like industry experts. If there are some conferences, I believe Anna was talking about some of those conferences, we will sometimes try to see if we can get some of our folks there as well, just so that we can hear from the folks in the industry to find out what's going on in those particular programs.
Great. Is there currently a process that is publicly accessible to file a complaint against an investigator?
Is there a publicly, so technically
there
in
a
the enforcement division, yeah,
process?
in the enforcement division, we're dealing with complaints with regards to the program. So I don't know that the department has an. Stephen, I don't know if you can speak on that part of it, but for the most part, we're trying to
Sure.
focus on complaints within the program.
Okay.
This is Steve Bruno, Deputy Executive Director. Thank you for that question. And thank you, John. Yes, if there's a complaint about a particular employee, you could write to myself as the Deputy Executive Director. You could write to our Executive Director, and you could also, another option is to write to our Human Resources division.
Great, thank you. Now I'm going to circle back around. Sorry for all the questions, but I was
No
just kind
worries.
of making
Absolutely.
notes
That's what
as
I'm
you
here
were
for.
talking. As far as I want to go back to the withdrawal process.
Absolutely.
Should a consumer make a complaint
Mhm.
and then suddenly withdraw their complaint,
Mhm.
is there any kind of exit process for that complaint to disappear? Is there an interview? Is there a written expectation from the original complainant? And this is kind of in the spirit of making sure that families or consumers that are making complaints aren't being bullied or badgered or unethically negotiated with outside of the spectrum of their complaint. Is there something from TDLR that follows up on these sudden withdrawals?
No, we don't typically follow up on the complaint being withdrawn. We typically take it at that face value. I will also mention this. This is an extreme rarity, but at the same time too, once a complaint is filed and it goes through the whole jurisdiction process and it goes into the investigation stage. Let's say during the course of the investigation, that's where the person has written in and saying, hey, I no longer want to pursue this. The department still retains the ability, much like the district attorney's office, still retains the ability to see the case through to a prosecutor if we think that there are serious health and safety considerations to go forward. So like we can still do that if we want to. Now the question will always become is, will we have the evidence to be able to support that if we think it's going forward? If we don't have the evidence to outside of that person to help us with that, if we don't have that, then we have no choice but to go ahead and close that case. The key to remember is we're always going to be evidence driven. If we don't have the evidence, we're going to have to close that case. No matter what the complaint is, maybe had initially alleged, if we don't have the evidence to support it, we can't take it forth to prosecution. We just can't.
That makes sense.
Makes very good sense. Mr. Medlock, this is Guillory. First of all, thank you. That was a very comprehensive presentation and answered really
Absolutely.
most of the questions, certainly that we had. But I think you just hit on it again. I keep bringing it back to if you had a consumer complaint, the complaint is the death of a child. It sounds as if you do an investigation, probably have an evidence, an expert there, but still, if there's no evidence, which it is in many cases, you don't know why. You can't find out the reason why. And even in that case, you don't go in a death. You can't go any further. You have to close the case then, if we do not have any further evidence about that.
Yeah, in all cases, whether it be an infant death or something very minor, if we don't have the evidence, we can't go forward. We cannot prosecute that case. So we're always going to be guided by the evidence.
Makes sense. Thank you.
Hi, Gretchen Robinson here. I'd had two questions for you, Mr. Medlock. We'll say hypothetically speaking, if a midwife receives notification of a complaint, but there's no identifying information, it just says that I am the midwife listed in this complaint. There's no information on the patient, the date of service, anything that identifies or mentions what the complaint is about, wrongdoing or improper documentation, whatever. In the event that that complaint or that notification is received by a midwife, what are our steps? How do we respond to that?
Good question. So just know, I believe Shauna talked about it a little bit earlier. So as part of the Sunset Bill that we had a few years ago, one of the things that they tasked us with was to keep complaint information confidential as much as we can throughout the process. And the reason is because the Sunset Commission felt, and it's kind of through their experience in reviewing different agencies, that I think too somebody was speaking earlier about maybe retribution for filing complaint, things like that. They want to make sure that that didn't happen. At the same time, ultimately, at the end of the day, you're going to figure out what it is. So the best case scenario is if you say, hey, we've received a complaint, or I've received a complaint, and you don't have that identifying information. Ultimately, we're going to have to be asking for those records, and then you will see that. We're just trying to keep that information as confidential as we can through the process until we need to reveal it, because at the same time, too, we want those people to be able to make an, when I say accurate, a defense against themselves. Defense is not the right word, but we want them to be able to tell their side of the story about what happened with that particular patient. It's just that initially you may not have that information, but please keep engaging with the investigator, and you're going to eventually get that information because we're going to be specifically asking for somebody's records.
Right, because initially, upon that first receipt, that first letter, the only thing that we can respond to is, like, I'll use myself as an example. Yes, I'm Gretchen Robinson. I have no idea what you're talking about.
Yeah.
And then we just wait for you to reveal what you're talking about.
Yeah, typically what happens is that first letter will probably be coming from the intake division. So the way that we typically do things is once it moves between different levels, there is a letter that gets generated and sent out. So once intake has determined that jurisdiction thing that I was talking about, they will essentially open the complaint for investigation. A letter will be generated saying, Ms. Rossi, here a complaint has been filed against you. Here's your investigator. Then the investigator will contact you and let you know, and y'all can discuss the story or what happened, the circumstances of what's behind that complaint. It's just that initially it was a sunset recommendation to try to keep confidential information across all of our programs as much as possible.
Okay, understood. My second question is a little bit harder for me to articulate. This is regarding checks and balances for the investigators. Is there a system set up? Is there a guideline for your investigators filing complaints. I'm harking back on my question earlier about consumer complaints versus investigator or internal TDLR department complaints.
Mhm.
Is there a system of checks and balances in place for your investigators about what they can file on? For example, hearsay. Or, I heard my neighbor say blah, blah, blah. I happen to work for TDLR. I'm going to file a complaint based on that, for example. Is there anything in place about accessing information from private communications between people, or just the concern right now is about internal from department complaints filed based on hearsay?
Mhm.
So is that something that is allowed, or is there a checks and balance system for your investigators? Like, we have to stay within a lot of guidelines. We have a lot of lanes to stay inside of. Do your investigators have the same?
They do. So we do expect our investigators to diligently follow up on every complaint or every investigation. Like I said, asking those who, what, when, where, how, why type questions, kind of following those threads as they reveal themselves. To answer your question more directly, like if a investigator spontaneously generated a complaint, that complaint is going to have to go through the intake process where we ask those questions. And if they don't have any evidence that alleges a violation, it's going to get stopped there. And then ultimately it might get moved. Let's just say it moved through that. It's going to have to get investigated. And then ultimately the prosecutor is going to have to review that. And if we can't determine that there's a violation, then there's nothing we can do to move forward with it. So most likely, or most times, cases that are departmental are not as a result of an investigator opening a complaint. Most of the times it's coming from another one of our divisions at TDLR because they've received information, or an outside agency has sent us information. That's the genesis most of the time of our departmental complaints. I'm not saying that we don't have an investigator that might be reviewing something and see an additional party that might be at fault. And it may be a situation where the person that's being investigated is actually should not be the subject of the investigation, but it's this other person. And so that's why they might generate a case to be open, because they're actually looking at the evidence, and the evidence is determining that the initial complaint is not who it should be against. It should be against this other person.
Okay.
Kristen
So
Bowers, Joe, just to clarify, um, we're specifically talking about fishing for information, outside of a complainant that maybe filed a complaint, not like a complaint was filed and an investigator did due diligence and, explored all avenues of people that might have been involved in a case. I mean, we're talking about so and so told me, and the investigator is now fishing for that information beyond in fact, a complaint, whether it was outside in the community or walked by and heard somebody say, "Oh, yeah, did you hear about midwife ABC?" And that's what's going on. Like, what is there a protocol for a TDLR investigator to open up a complaint exclusively from information that they went out and found arbitrarily based off of hearsay?
The way I will kind of answer that question is we typically do not go fishing for information. And what I mean by that is we are typically complaint based, which means that there typically has to be a complaint. Now, we do reserve the right to perform and conduct sting operations, which we do in a lot of our some of our other programs, building mechanical type programs, because we do have a lot of unlicensed activity. But that's not to say that if we don't hear information, especially if it's concerning health and safety, that we're not going to look into it without having a complaint generated first. So if we are receiving information where health and safety is being impacted and affected, we are going to take a look at it and determine whether or not we do need to open up a complaint.
Gretchen Robinson, just to follow up on that, what about complaints that are generated from information that could only possibly come from a confidential peer review?
We don't question how information comes. If it comes through our complaint-based system, we have to just evaluate it for, again, the jurisdictional issues, and then we're going to investigate it.
But if it comes about during your investigation that it's realized this information was shared from internally within a confidential peer review, is it then not touchable? Or how does that, where are our protections for confidential peer reviews?
Our basically the bounds of what we can look at is whether or not something is a violation of the laws and rules. If something is a violation of laws and rules, the statute allows us to be able to investigate and enforce those violations.
So just Kristen Bauer, so just to clarify, a confidential peer review is not exempt from a complaint review through TDLR. Is that what we're saying?
I mean, in terms of our investigation, yes. Now, again, depending on how you, like, let's just say that a case came through that manner, that mechanism, and the person that it was against decided to take that case before the State Office of Administrative Hearings, the rules of evidence do apply there, right? And when we make these determinations, when I say we make these determinations, when we decide to go after someone, in the back of our minds, not only are we thinking about the violation that we're seeking to go after, but we're also thinking in terms of, okay, if this person decides to go to SOA or the State Office of Administrative Hearings, how am I going to get that information in before the court, right? Because we are bound by those rules of evidence. And if it's evidence that is not admissible, then I probably can't use it in my determination. So in conjunction of that's kind of like the part of the thing that the attorney is looking at, kind of the calculus that we're making here, is that once one part of it is what's being alleged a violation of the laws and rules? Okay, if it is yes, then the next part of that calculus is, do I have the evidence, or will I have the evidence that if I need to admit into a court, can I prove that? Can I get that stuff admissible into court? If it is a violation of yes, but I can't get it into court, that's going to go into that calculus of whether or not I'm going to issue that notice of alleged violation. Because if I can't ultimately prove it to an administrative law judge, then there's not much I can really do with it. Because again, we're going to follow the evidence, but part of that calculus of following the evidence is that evidence admissible?
So I guess then my follow-up question is confidential peer review considered admissible
I would have
as
to take a look.
evidence?
I would have to take a further look in conjunction with all of your laws and rules and what the applicable rules of evidence would state on that. I can't give you an answer on that right now.
Okay, I would like at some point to come back around to get that answer. That would be very informative. If we can put that on the list, or maybe add that to the, I don't know, or if that would be like an enforcement committee thing that we can have a discussion, that I think that would be important.
Yeah, we could probably have that discussion that way.
And Derek Burkhalter, just to kind of piggyback, it's going to be very dependent on the specifics of the case. I mean, it may be admissible for one purpose, but not for another purpose in court. And so I don't know that we're going to be able to provide you a bright line rule. I mean, the rules of evidence are legally what they are, and it will just depend on the situation. And so, I don't think our statutes speak directly to a peer review program. And so a judge would have to look very carefully at all the relevant laws, the rules of evidence, and depending on what the evidence is being used for, you will get a different outcome. So I just want to kind of adjust the expectations. I don't know that we'll be able to provide that bright line rule for you.
Gretchen Robinson, I understand what you're saying, but as was just said, you're not asking where this information came from in your initial looking at this complaint, going through your checks and your process. You're not asking where this came from. And for us, as a community midwife standpoint, confidential peer review is essential to our growth, our understanding, our helping each other to do better within our own community. And there's been a lot of issues with that recently, that what is shared from the heart, maybe questions that could be posed. Hey, I have a question about X, Y, and Z. And then we have to worry that the fact we're not confident maybe on something, or we share something from the heart, is going to be turned around into a complaint. If you're not asking where this information comes from, and you don't know if it's from a confidential peer review, you're running with something that maybe down the road you can't even use. And meanwhile, we don't have this safe system for us to grow within. We don't feel safe even in our own peer reviews anymore. We don't know where the line draws with y'all. We don't know what's not admissible. We don't know what we can and cannot feel safe sharing within our own community anymore.
And I'm sorry to interject again, Derek Burkhalter. This subject is getting dangerously close to something that's under litigation right now. And so I have to kind of be careful and advise staff to not make statements that could affect that litigation. And so I think we hear you, and, we want to provide as much transparency and clarity as we can, but we don't want to affect pending litigation that is addressing something very close to what we're touching on here. So I'll just kind of ask that we stay within that limitation.
Ma'am, I think you're on mute.
Thank you. This is Jennifer Kelleher. I have another follow-up question to my long list of questions. When a complaint is investigated, reviewed, closed, is there ever a process that the midwife involved can request all of those discovery documents, or are those off limits, or does that become part of public record once that case is closed?
So there is a provision in Chapter 51, which is TDLR's kind of enabling authority. And there are a certain list of programs, Midwife being one of them, that do have this extra layer of confidentiality to it, which pulls things away from disclosure during the open records process. However, with that said, if you are the direct respondent in a case, you can get that information.
And where would we find the information? Where would we find the process for obtaining
You would
that?
have to go through our open records division. On our website there, I believe there's a link for our open records division, and there's a way that you can go into the portal and request that information.
And is there a statute on how long those records are preserved?
There is statutes about records retention. I'm not 100% sure. I know orders are 20 years. We're required to keep orders for 20 years. In terms of, like, if it's a closed case, I don't remember exactly what that retention period is.
Okay,
But
thank you so much.
it is much shorter. I will tell you, it is very much shorter, not the 20 years.
Okay, for a closed case.
Yes, ma'am.
Okay, thank you.
Michelle Gold here. Hi. Are there guidelines for the corrections? Like when a case is closed because they've made corrections, or did the, when there's like the 3 no-avs, what was the middle one where there's like a case closed?
Oh, the
Warning letter,
the
the warning
the
letter,
informal
yes.
resolution.
Yeah. Are there specific guidelines, like what counts as a correction?
No, because it honestly kind of, that's usually a process that's kind of worked out honestly between the respondent and the complainant. And each situation is a little bit different. It could be in a tow truck case, it could be maybe they had to move the sign tire, right? Maybe in the air conditioning, they came back and fixed the system. So it's going to be a very fact dependent and program specific kind of, determination.
Okay, so if somebody had, like, say in their standing orders, a line that didn't fit with what we do, and they remove it from the standing orders, they get it signed again. That could be, that could fall under the correction.
Yeah, that could possibly be something, you know, it could be something that we reviewed the standing orders, and even though this is not allowable in the standing orders, but that was not necessarily the focus or the subject of what the whole thing was, that could be a situation where I could see that happening.
Are peer reviews counted in corrections? Like if somebody goes to a peer review and gets constructive feedback from other midwives?
Without seeing the case specific, it could be. I'm not saying that it's not. I'd have to see that whole fact pattern to be able to answer that thoroughly.
Okay. All right. Thank you.
Yeah, absolutely.
Hi, this is Danielle Hurst. Mr. Medlock, I sure do appreciate you giving that very in-depth presentation. It has been absolutely helpful to see it from your point of view and to see how some of this stuff works in the background. I come from a law enforcement background, so it's incredibly, I think, just lightning, right, for me to see this, because I have seen a lot of things through investigations where I think it's super important for people to know the avenues that someone can take to make complaints, and then therefore see the different I guess remedies that that could happen. But I've also seen the program exploited in different ways, and it's really disheartening. Things that I think that some of the midwives who are trying to conduct, their practice in a very safe and a very healthy manner. And so when you talk about preponderance of evidence in some of these complaints, right? I mean, that's, speaks very closely to me. So for me, it's like you said, 50 and a feather. Do you work with your state and federal agencies to kind of see where you can get additional information? Because I can definitely see where some of these cases where you're on, the notice of alleged violations, when you fall short of that, if we were to maybe liaison a little bit more with federal and state agencies, then that would put you more into the alleged violations, and then maybe, can clean up some of this mess that some, unfortunate midwives are causing for the rest of the organization. But so my question is, one, do you work with law enforcement agencies, state agencies? Do you share information? And then number two is there, how many investigators, the state of Texas is very, very big, and I've seen it move very slow. What are the numbers there that we're looking at? Because your complaints are, they're large numbers. So
Absolutely. To answer the first question, do we work with state and federal authorities? Yes, we do not just this program, but in a vast variety of our programs across, as you can tell. There is nothing that we don't do at TDLR that does not affect the lives of any of the 30 million Texans every single day across our programs. So yes, we are definitely in touch with our law enforcement partners. It sometimes is a little bit more in certain programs just because of the nature of the program. But in situations where avenues present themselves to be able to work with them, we are always willing, able to collaborate with state and local officials. In terms of the second question, we have approximately 45 or so investigators for the entire state. They are broken up into regions. We kind of have a north region, kind of an east and south region, and then kind of a more of a central kind of a region. Not all of those 45 will work on this program specific. We have a few that will work on this program along with some additional other programs as well. And the reason we don't have larger staff is we're constrained by our resources that were allocated through our budgetary process. So that's kind of just the simple answer of what that is.
okay, thank you so much. Go ahead.
Sorry, Destiny Hooper here. Just a reminder to keep your camera on at all times if you're on the board so that you can count for attendance. And we're going to have another 10-minute break after we finish up the agency update before we move into agenda item G. So if we can move on to the agency update, I'll call on Steve Bruno, Deputy Executive Director, and Caroline Espinoza, Director of Strategic Communications.
Well, good afternoon. Thank you, Presiding Officer, and thank you, everyone. It's good to be with you. I'm Steve Bruno, Deputy Executive Director for Licensing and Regulatory Services. I wanted to begin by addressing a topic that's come up through public comment and through the discussions today. We have received multiple comments regarding enforcement activities during a recent investigation, and I do want everyone to know that we appreciate your feedback, and we are reviewing the concerns that were raised. We handle, there was a question about, and I answered that complaints or concerns about personnel could be directed to myself, to our executive director, to our human resources department, and that's all true, but we have an internal process to review personnel issues, and that's what we'll carry out. It's obviously something I'm not going to talk about or not able to talk about in a public forum, but I do want you to know that we take our goal very seriously of carrying out our regulatory responsibilities in a manner that is fair and professional and respectful to everyone involved. That includes both the public that might file a complaint and you as the communities we regulate. We recognize the importance of that trusted relationship. Again, this is an open investigation, so I cannot discuss specifics, but I do want to assure you that we have heard your concerns and they are being taken seriously and they are being addressed. I want to thank John for his presentation, and I want to thank you all for the comments. We recognize that the enforcement process can be frightening and intimidating, and I hope that the presentation today has helped to open up a little bit more of that, to make it transparent. I hope that I expect that when we get to agenda item I, we may see some recommendations for further discussion based on things we heard, you all heard in public comment. And of course, we would welcome that. Some other updates I wanted to give you across the agency are an update on what we call our CORE, C-O-R-E project. It's a very exciting 3-year project. As those of you who have been with us a long time know, we have a variety of systems that we've inherited in which to process licenses and conduct our business. And we are consolidating into one licensing system called CORE. We've launched, our first couple programs already on that system. Yours will be coming on later on. And as we get toward that date, I will be giving you updates. And one important feature that we are including in this rollout for each program is that we'll reach out to a few of you on the advisory board. Of course, we have to be mindful of any quorum issues, but we'll reach out to you before your program goes live on the TDLR core system to give you a feel and have you walk around and kick the tires, so to speak. We'll ask you questions and you'll be able to give us feedback on what you think. We've got a couple goals in mind for this system. We want it to be user-friendly. We want it to be user-friendly for you, and we want it to be user-friendly for us. We want it to be secure. Every day there are new threats with cyber attacks and people trying to steal information, so security is paramount. And we want it to be flexible and modern. As we know, our programs might change based on legislative activity, so we want to be able to accommodate that. It's going very well so far. As you can imagine, with any large project, there are unforeseen hurdles, but we're working through those, and it's a very exciting opportunity for us to help give you a tool that works better for you and that works better for us. I will be turning over to Caroline Espinoza in a minute to talk about strategic plan updates. But if anybody has any questions or comments about what I've just said, I'd love to take those.
Michelle Gold here. Thanks, Steve,
Hi,
for
Michelle.
that. Hi.
Good to see you.
Do y'all have a timeline for us? For the
I
court?
don't. Will be able to get you one before the end of the meeting.
Okay.
It's not soon, but let
Yeah.
me work on that, and I will provide an update before we conclude today.
Great. And then I remember that Shauna said on the Shauna Mashuk said on the report for the enforcement division that all the reporting systems were the same. Is that going to change with the core system? Like, will we be able to kind of get more specific data that we've asked for?
We hope so. That's one of the goals. Absolutely.
Okay.
Yeah, is easier information for us to extract so that we can answer the questions that you all have. Absolutely.
Great. Thank you.
So that we can do, John mentioned some of the sunset recommendations. Just quickly, one of them is to make, data-based decisions, data-driven decisions. And so the better our systems are, we believe the better and more accurate data we'll be able to share to help make those decisions and be able to share that information with you.
Yeah. Will it do anything for the complaint process at all? Having better data?
Right now it's focused on the licensing side.
Right.
But we will look at integrating that and making sure that it's as smooth and seamless as possible. Thanks. And with that, I will turn it over to Caroline.
Thanks, Steve. Good afternoon, everyone. Thank you for your service on this board and for your time today. I'm Caroline Espinosa, Director of the Office of Strategic Communication here at TDLR. Every biennium, TDLR develops a strategic plan, which is required by the Legislative Budget Board and the Governor's Office. The Texas Commission on Regulation and Licensing approved the plan at its meeting on May 20th, and the plan was submitted to the LBB on June 1st. The plan is available on our website from the front page if you're looking for it. As part of the strategic planning process, agencies are asked to identify statutory, regulatory, and operational redundancies and impediments, as well as opportunities to improve efficiency and effectiveness. This year, a new requirement was introduced. Agencies were also asked to identify programs for realignment, deregulation, or transfer. In developing recommendations, TDLR evaluated a variety of factors, including recommendations and observations from the Sunset Advisory Commission process, the Texas Regulatory Efficiency Office review, operational experience, and stakeholder feedback. We received quite a bit of stakeholder feedback at the public meetings that we held as part of the strategic plan process, as well as through social media and emails that we sent out requesting feedback. Of specific interest to the midwifery program, the strategic plan includes a recommendation to change the fixed expiration date of midwifery licenses to base it on the date of issuance in order to reduce the administrative burden and increase efficiency in processing renewals. It was something that we talked about earlier in this meeting. There's also a recommendation to create a student permit for those who are participating in clinical midwifery training in order to improve oversight and accountability. Specific to the new requirement to identify programs for realignment, deregulation, or transfer, the plan also includes a recommendation related to resources and the future placement of the midwifery program. That recommendation reflects that TDLR has not historically regulated medical programs and that certain health-related professions involve complex clinical and standard of care considerations. Similar recommendations were made for other medical programs under TDLR, including the podiatry program. While TDLR has worked to supplement its capacity through contracted subject matter experts, maintaining the depth and continuity of the expertise necessary to fully support this program presents an ongoing resource challenge. With appropriate additional resources and a dedicated medical support, TDLR could continue to regulate the program effectively. Absent that level of support, placement within a health-focused agency with embedded clinical infrastructure may offer a more aligned framework for addressing standard of care issues. This process provided us with an opportunity to identify this ongoing need for specialized expertise to effectively regulate programs and fulfill our core mission of protecting Texans, supporting regulated industries, and maintaining public trust in an increasingly complex environment. The recommendation recognizes that there are multiple ways to address those needs, including providing additional resources to TDLR. Absent those resources, it may make sense to transfer the program to a health-related agency. I would like to emphasize that TDLR is not making any decision regarding the future of the midwifery program. The strategic plan is intended to inform policymakers and support discussions during the legislative process. Any decision to transfer, retain, or otherwise modify a program would rest with the legislature and would require legislative action. Nothing in the strategic plan changes the current regulation of midwives, the operation of the program, or the role of this advisory board. TDLR remains committed to regulating the profession and supporting the important work performed by licensed midwives across Texas. And if you have any questions, I'm happy to answer them now.
Yes, Kristen Bowers here. When you guys were exploring the department or other programs that would, I mean, presuming the staffing or the resources at TDLR wasn't able to go through, what departments were identified as possible places that the midwifery program would be transferred to?
We don't presume to make that to make any of those assumptions. Again, this would be something that would rest with the legislature, and that would be a decision they would have to make.
I guess clarification, I meant when you were identifying options, or maybe that's the same question, but if you were identifying like places that might land, obviously not TDLR's decision is what you're saying, it would be with legislatures, which ones were being identified as possibilities, I guess, if that's something that you can answer.
Outside of a health-related agency with that embedded clinical expertise, that was it. We did not identify any specific agencies.
Hi, Michelle Gold here. You mentioned the word medical. We don't practice medicine. You did mention the clinical care aspect, but I
Mhm.
think in the strategic planning PDF, it also does say specialized medical expertise. And I just was curious about that use of language.
Well, outside there, we have a number of health-related industries that we regulate, and because while midwifery may not be considered specifically medical, it does involve, in many cases, transfer to medical care, and so would fall under that category. Any other questions? Thank you very much.
All right, Destiny Hooper here. We will take a 10-minute break. It is 1:45, so we will resume at 1:55 p.m. Thank you. You're there, if you can turn on your cameras. And Ms. Marshall will take roll once the cameras are on.
Danielle Hurst.
Present.
Kristen Bowers.
Present.
Gretchen Robinson.
Present.
Jennifer Kelleher.
Present.
Michelle Gold.
Present.
Melissa Bates.
Present.
Dr. Guillory.
Present.
Dr. Nix.
Present.
And Presiding Officer Destiny Hooper.
Present.
We have a quorum.
All right, great. We will jump right back into it. I will call on Michelle Gold to present the Standard of Care Work Group Report.
Thank you, Destiny. So yes, we met on March 25th. I felt like we had a really good, productive meeting. We got a new draft presented to us at that meeting. The draft that was presented included the following changes. The neonatal resuscitation was added back to the form. The reduction of the amount of wording in the malpractice liability insurance section was taken out. Backup midwifery care was added. The wording, quote, non-transfer was added to the medical backup arrangements along with some additional information. And then there was a paragraph stating that the client become familiar with the local hospital that was to be encouraged. So during the meeting, we made the following changes to that form. And I don't know, do you want to go through it while I do this? I don't know if you want to scroll down, or I'll do the bullet points and then we'll go through it. But there was a clarification on how many births a midwife was the primary attending midwife. And then in the I am required to section, there is a quote, unless you object, that was added to the statement concerning eye prophylaxis specifically. In the backup midwifery care section, we changed the wording to, if I'm temporarily unavailable to provide your midwifery care, fill in the provider's name here, we'll provide continuity of care. Additional wording was added with a summary stating that non-emergency transfers, consultations, and referrals to medical professionals is sometimes necessary. And then a final paragraph regarding hospital transfers was revised into a bulleted list. The language was amended to encourage discussion with midwives. It's really discussion between the midwives and clients, potential clients, about potential transfer details. And so I think that's what we did as a group. Do we wait to see if anybody has questions?
Gretchen Robinson, I have a question. Sorry. Yeah. Did these revisions come since the last advisory board meeting?
Yes. So after the last advisory board meeting in January, when we met on March 25th, we already had a new draft from TDLR, and then we went through that draft and we revised that draft. And
was
so
that new draft sent out to us?
No, just the work group got it. It was presented to the work group.
The final draft, this is Anna Clark, TDLR. The final draft should be in your packet behind this one. Let me know if y'all want Carmen to share that one as well.
I think it probably, do y'all want to see it? I think it'd be good.
Yes, please, because I don't recall seeing it. I must have missed it.
Were we going to share it when we get to item H?
Oh, yes. Yeah, we can do that. So this, for item G, it's just a summary of what a work group did during our meeting. And then item H will be an actual review of what the form looks like after our work group meeting and after all of these subsequent emails that would happen for.
All right, great. So we will call on Athena Ponce, Assistant General Counsel, to discuss the proposed changes and revision of the standard of care work group to inform choice and disclosure statement.
Hello again, advisory board members. I'm Athena Ponce, Assistant General Counsel with TDLR, and as was discussed by advisory board member Gold and that Anna alluded to as well, we did provide the updated draft form and the advisory board packet that was provided to all of you. It should be after the work group report in that packet, I believe. I am also now going to share my screen just so that I can show those changes and we can all look at them together. I believe that Ms. Gold did pretty thoroughly cover everything that we worked on. So can you all see this screen clearly?
Yes.
Okay, so you will see in the first box that neonatal resuscitation certificate expiration was put back on the form that was raised at the last meeting. In the second box, you can see the language was the primary midwife attendant at blank births. That's some updated language that the work group thought would be a more descriptive, accurate, and informative kind of language for the client to understand the midwife's experience. As was mentioned, the eye prophylaxis disclosure, now we are suggesting the language unless you object to conform to statute that was raised during the work group. And the form still has language that we had suggested prior that may not perform frenotomies or perform an abortion. That was not asked to be removed during the work group. The professional liability insurance, the proposed language is shorter than what had been proposed before. And this language here in yellow is what the work group agreed upon as satisfactory. And there is a new box of backup midwifery care explaining if I'm temporarily unable to provide your midwifery care, this provider will provide continuity of care, and it has contact information and space for client initials. This would be new information to provide more information to clients, and this was also suggested during the work group. There's also additional language or updated language on the last page that clarifies and explains early on to clients that sometimes my midwifery care will involve consultations, referrals, or non-emergency transfers of care that include medical professionals. My decision to recommend medical care will consider a provider's qualifications and your ability to access the recommended care. So you can see there that the language in this paragraph is contemplating a discussion or recommendation from the midwife to the client, and this language was suggested and considered satisfactory during the work group and follow-up discussions. And then further highlighted in yellow, in the event of an emergency, if you are not transferred by an ambulance, you will transfer by vehicle to one of these hospitals listed in order of nearest proximity to your planned birth location. So we added that language just to give a little more sense of organization for midwives and clients so that they would understand which hospital is closer than the other on the form, since that is something that comes up during transfers and recommendations for transfers such as through EMS or dispatch. And then at the end, we have this advisory language. Although a transfer may not be your original plan, it is sometimes required for the health and safety of you and your baby. It is recommended we have a discussion about the possibility of a hospital transfer and any preparations a transfer may entail, such as familiarizing yourself with and visiting the hospital, pre-registration with your chosen facility, preparing a bag to take to the hospital. And if you have any questions or would like to discuss other aspects of transfer preparation not covered here, please discuss with me, your midwife. So this advisement language provides an opportunity for a discussion between the client and the midwife to consider such situations that may arise and for the midwife to give her opinion as to what to consider and what to prepare for. And once again, this language was discussed by the work group and considered satisfactory and agreeable. And everything that is in this form in yellow that was provided to you all is that indicates the language is new in comparison to the language in the current TDLR form, except for the neonatal resuscitation certificate that is on the current TDLR form. So that's not in addition overall. This is just an update as to the form that had been presented during the prior advisory board meeting. So we can answer any questions, and work group members may also want to answer questions. But as Ms. Gold spoke to, it was a very productive discussion. There was a lot of feedback and a lot of listening, and the midwives provided feedback, the doctors provided feedback, and this seemed to be a very good resolution of ideas for everyone involved. If you all are fine with my stopping sharing, I can do that, or I can leave the document on the screen.
Can you leave it on?
All right.
This is Melissa Bates. I don't know. I mean, obviously, I'm thankful that the work group met. I'm glad that they were able to come to some consensus. I do have a concern as far as, I think it's on the second page where the backup arrangements are listed. I don't know about everybody else, but for myself and my own practice, this can vary either month to month or situation. Just again, I can't plan if I'm going to be at another birth and then have somebody else step in for me. If it's a known thing, like if I know, I have a family vacation coming and I made arrangements for, that 1 week, I might have a provider who agrees to say, yes, I will cover your clients for that week. But if there is a, unplanned situation, like I said, either I'm at another birth, it may or may not be that same provider. Also, because they too would be a midwife. The thought process is they also have clients, and so they can't guarantee availability for my clients. So I have reservations in that one that could change for each person, even known, because even if when I'm out of town, the person that I had picked to be my backup, if she's with her own client's labor and she has to call someone else, I've trusted her to make that call. But is there any liability to her by being named as my backup should in fact something happen and then the client have any kind of recourse as to this person that I was promised to be at my birth wasn't there? What is the implication there?
Would you, this is Athena Ponce speaking, TDLR Assistant General Counsel. Would you say in the situations that you're describing, even if a certain midwife is typically designated, or maybe 2 or 3 who you typically choose from, would you say generally and eventually there's only 2 to 3 midwives who may possibly be involved in the care? And the reason I ask is because, for instance, the transfer of care to hospital part of the form does have advisement that another page may be attached if more hospital information is necessary. So do you think it would be helpful if we had something for backup midwifery care, something like more names may be attached to this form of who may provide your care if those are people you regularly rely upon?
I don't, while I would say yes, I might generally rely on up to 2 or 3 people. One, I think adding to the length of the form is still cumbersome. Two, I think literally just naming and kind of having in writing might imply some sort of a contractual arrangement that shouldn't be there. It also, in addition, right? Like if I'm having people help me, I want to be willing to help them, but I don't know that I want to be listed and named on their form with all of my information so that clients could come back and be like, here's this midwife. I was listed on their form. I've never met them, but they're going to include me if they were disgruntled or upset in any reason. I think that could hinder relationships.
Just to kind of add to this, I mean, we actually have a situation, that could arise, like where I am in a group practice, so it makes it easier for me. I can just list, the other midwife. But if you were a solo midwife and something happened, I mean, we all just as a community, especially when we're in larger areas. I mean, I understand like if we're in a smaller area, then they have smaller groups that are backing each other up as providers. But in larger areas, I mean, we have a whole number of people that we would call. So yes, I agree that it would probably be cumbersome for me to list out like all of the midwives in Houston that I may end up calling, potentially if there was a conflict, and then turning around and listing all of their contact information as well. It also tends to be at the discretion of, the client. If they were different midwives they might be looking for, I would call for different reasons, obviously.
Mhm. Gretchen Robinson, just to piggyback really quick, would it be possible to maybe just say that in the event the unforeseen event, I'm not able to be there, a licensed midwife in good standing will be provided for you? For myself, this is at my own cost as well. I don't know necessarily if that needs to be stated, but if I have to call back up, I have 3 midwives I trust with a wide variety of experience and skill and specialty to call for any situation should I need it. The current document as it stands right now does have the space for me to type in those midwives, those 3. But what if they're not available? Then we fall into that. Could we just say that in the event I'm not available, a licensed midwife in good standing with the state of Texas will be provided to you? I think that would be more of a blanket coverage. We're not naming anybody. We're leaving that discretion of who to call to the midwife. Maybe that's an option.
Destiny Hooper, I agree with that. I think that's a good idea. And also, it could say something like, when the need arises, more information would be provided to you of who the person is, if it by case basis.
Yes, because we work in a mixed practice, so it might be a CNM, it might be a licensed midwife, but a valid provider would be found. We would never leave a client just hanging. I mean, that it goes against everything that we do.
Yes, exactly. And then we run the risk of this parent, I'm imagining a first-time mom sees that name and says, "Oh, well, if you're backup, I want to contact you. I want an appointment. I want to meet you," which is fine and dandy. But I would hate for her to reach out to my backup, Christine, for example, and say, "Hi, I'm Gretchen's patient," and you're on the form, and Christine's got no idea who this person is because I'm going to call Christine in the moment. I'm not going to alert her, "Hey, I've put you down on all of these forms." So a lot of miscommunication possibilities can arise from this current proposed addition right here.
Is there anything that's currently done in practice that you all would say you do upfront that's similar to this? Or is it more as the need arises, as you just said?
Sorry, Gretchen Robinson. For myself, when I go through this form, I just tell them, I have a couple backup midwives. They're local to me. I have an established relationship with them, feel confident and comfortable in their knowledge and skill, their personality. Should I be unavailable, one of them, would be contacted to step in for me. And they're usually just fine with that, knowing that at the end of the day, in the moment when everything is happening, that there's a good licensed midwife available. I've never ever had somebody come back to me and say, well, I want to know exactly who all the people are. I want to meet them. I want their information. They're just happy to know that I'm looking out for the what if situations.
Jennifer Kelleher here, and I do something very similar in my own practice as well. It's usually at an interview stage or initial consult, initial appointment stage. We do talk about what happens if I'm not available, and generally, fortunately, I practice in an area where there are lots of accessible midwives, and that is just kind of disclosed that I would call in and make sure that there was somebody assigned to whoever I was unable to attend to, and that information would be exchanged as needed. I think that just saying a licensed midwife will be accessible in the event of if I'm not available, will be provided in writing, perhaps, might cover that base. I feel like it would be redundant to say licensed midwife and in good standing. Good standing can be objective.
Or even not putting licensed midwife, just another what's the word? Another provider, another because I work, like I said, I work in a mixed practice, so I would be transferring to a CNM.
Yeah. So maybe just leave it at.
And just
On a
for
clerk
the record,
TDLR.
I'm not opposed to the statement. Like I'm okay with like backup midwifery provider, because we really should be discussing making sure that they're aware. Yes, we're gonna call somebody. So I'm not opposed to the statement. I think that it's fine. I'm just saying that the listing the actual provider, I think, is what me personally, I speak for myself, is the difficult part, because it is a very fluid thing depending on what's going on.
Okay, so based on, this is on a Clark TDLR, based on what y'all are saying, I have written down, if I am temporarily unavailable to provide your midwifery care, a licensed provider will be provided to you. When the need arises, their contact information will also be provided.
That works.
Fantastic. Thank you.
And I maybe for clarification, just for like a non-medical reason, obviously this is excluding transfers. If we are transferring care to a higher level of care, like from us to a hospital, I am not providing a doctor for them. Like we are going to go get the doctor and they're going to go to the hospital. This is for like, oh, I have the flu and I can't be around you and your brand new baby, and I need to make sure that you have coverage. Like, yes, of course I'm going to cover the person. I'm going to pay for that. But if it's like, oh, you have hypertension and preeclampsia, we need to go to the hospital. No, I'm not covering a hospital bill for that. So just maybe, I don't know if that was just me. I kind of felt a little vague. Sorry.
I don't think there's any discussion on the document about who pays who, when, and where.
No.
I don't think. Yeah.
On a Clark
That's
TDLR, there's also
in
another
our
section
contracts.
about, I'm sorry, there's also another section about medical professionals on the next page at the top to kind of separate midwifery care and medical assistance.
Gretchen, did you have something to add?
No, man, I was just agreeing. I was in agreement about, we don't pay for a hospital bill, but that's also covered in our financial policies as well. So I feel like not having that on here would be fine.
So this is Athena Ponce speaking. considering that it sounds like the consensus is backup care could include a midwife or a certified nurse midwife. Is there any other provider that you feel like would fall into this backup category that makes backup midwifery provider care inaccurate, or is it fine to leave that as the title?
Kristen speaking, I mean, I feel like that's fairly accurate since those are the only midwifery providers in Texas.
Mhm.
Danielle Hurst, I have a question. Is this the only form that patients get, or are there other forms presented that perhaps might, answer more if the patient had more questions, they could find it on another form that addresses that.
This is Athena Ponce speaking, Assistant General Counsel, TDLR. In terms of what statute and rules require, I believe that this is in terms of orientation and accepting care, this is the only thing required by statute. However, that does not mean that midwives themselves do not have all kinds of forms of their own to provide information to document consent, to document agreements to certain decisions. I cannot speak with them in several respects as far as that goes. They themselves may want to provide some examples of forms or documentation that is kept by statute and law. They are required to keep an ongoing healthcare record that is regularly updated and reflects visits and healthcare status and important information accurately. But in terms of what TDLR is responsible for that midwives may provide, this is the only form that I can think of right now that would be required by law during a consultation.
Okay, so this form you're obligated as a midwife to give this form to your patient.
Kristen speaking. Yes, this form is it's obligatory for us to provide this at their consultation or to review it with them so that they can see it. But it is not in lieu of other forms. Like our practice has several other midwifery consents, financial consents, disclosures, all the things. This is just the basic summary for a licensed midwife.
Okay, Daniel, is a form also available in different languages?
This is Athena Ponce speaking, TDLR Assistant General Counsel. By statute, the form is required to be in both English and Spanish. So once the form is fully agreed upon to be put on the website and provided to midwife clientele, the form will also need to have a Spanish version under statute.
Thank you.
This is Jennifer Kelleher. I also wanted to comment that the public comments in regards to this form that were sent to us a couple days ago. When we did this work group, we did not have access to all of those public comments, which would have perhaps been helpful. But there was a public comment that caught my eye in regards to the frenectomy bullet point and the abortion bullet point in the legality umbrella of being actually by listing those. And I just wanted to circle back to that to make sure that there was nothing valid about that public comment in regards to being outside of our lane, if you will.
Athena Ponce, Assistant General Counsel with TDLR. Do you mean that, are you asking if it is possible that frenectomies and abortions may be permitted to be performed by midwives, so it shouldn't be on the form? Or are you saying something more like we should have only in the form what is listed specifically in statute and no further?
Unfortunately, I can't remember exactly what the comment was because I read 171 of them last night. And I could circle back around and try to find it, but there was a pretty detailed reference in the fact that by listing the fact that we cannot perform frenectomies or perform abortions, was not in line with the rest of the document or the regulations of the document, not indicating that we can perform them, but just by listing them at all.
Athena Ponce, Assistant General Counsel with TDLR. The statute that requires and authorizes this form, in conjunction with the rule that authorizes the form, the statute lists a minimum of information that must be included, and then the rule further elaborates that the form that is created based on the statute is a form that is to be developed by TDLR, and it is the form that will be used. So the statute is written in such a way that tells TDLR at a minimum the language that must be in the form and cannot be excluded, but it does not limit or prohibit additional information that would be correctly in line with statutes and rules that govern midwifery practice.
Jennifer, I was looking at the comment that you are just that you're speaking of, and without mentioning anything directly about the comment, I think what it sounds like, Athena, you're saying is that if it's already been passed through legislature and placed in the scope or taken out of the scope or clarified as far as scope of whether it's in or out in the midwife legislature, then it can be added potentially to the TDLR form. But the TDLR form is not, in fact, establishing scope of a midwife. It's more just presenting what's already scoped through law to a potential client. Is that correct?
Athena Ponce, Assistant General Counsel with TDLR. Yes, that is correct. It is just simply a recitation in several parts without the form of what is already statute or rule.
So just to clarify, that verbiage does have to be on the form?
Athena Ponce, Assistant General Counsel with TDLR. Which verbiage are you referring to?
Destiny Hooper, I'm referring to what Ms. Kelleher asked about the frenectomies and abortions.
Athena Ponce, Assistant General Counsel with TDLR. It is not required in statute, in the informed consent statute, to have those two particular items. There are other items that are in the form currently on the TDLR website, and those are required at a minimum by statute.
So to clarify, Destiny Hooper, to clarify, are we able to remove it from the form?
Athena Ponce, Assistant General Counsel with TDLR. If we removed frenectomies and abortions from the form, that would not be a violation of statute or rule. The reason that we included them is because there have been allegations, and I do not want to get into describing enforcement's work or to speak for them, but we did not arbitrarily add those two procedures. It was not an arbitrary decision. There was a basis for doing so.
Okay, I
Athena,
understand.
this is Anna Clark, TDLR. Would you mind scrolling up to that section? It's the top of page 2. Thank you.
Gretchen Robinson, really quick. If we're going to create a trend of putting a bullet point for every time a midwife practices outside of her scope, this page potentially can grow over time, which I would hate to see. But I'm a realist as well. Is it maybe a more efficient thing to say, here is where you can find our administrative laws, our scope of care? I think that's already on there, isn't it? Not just the complaint at the bottom, but where they can find a listing of what we can and cannot do, instead of bullet pointing maybe everything. I do
Christina,
understand what you were
Gretchen,
saying, that it wouldn't be on there if it wasn't happening. It's the Tide Pod rule, you know, that warning label, don't eat, isn't there just for fun. So
Christina, Gretchen, are you speaking about the directing them to the midwifery rules, basically?
I can't see what's being highlighted there.
I'm not highlighting
There
that,
it
but
is. Okay, yeah. But I was just spitballing, instead of, you know, itemizing, we cannot do this, we cannot do this, maybe making that a little bit more visible. I'm just going to make an assumption and say that that's probably not noticed very much there at the bottom of that page. If it's important enough to state we can and cannot do X, Y, and Z, maybe just saying, you know, for a full list of our scope of care and capabilities, please see. I don't personally have a problem with the frenectomies and abortion being listed. I'm just thinking long-term down the road. That's all.
Melissa Bates. Well, I agree, because part of the issue is, why then wouldn't you list, okay, we also can't do surgical deliveries, right? So you're looking at something that right now it doesn't seem like much to add to bullet points, but literally if we list everything we can't do, it becomes ridiculous.
Mike Nix.
So volunteer. Oh,
I
sorry.
think listing the most important things that may come up more frequently or may have more of a chance of occurring illegitimately may be a better idea, may be worthwhile. You can't list every possible thing that someone can't do, but you can list the ones that are most likely to come into play. And I think that was what the spirit of this was.
Danielle Hurst, just making a comment on like the investigative side. I definitely agree with piggybacking on what you just said. If you list the most frequent or things that are more likely to occur on the investigative side, or when we're talking about ramifications or to hold midwives accountable for, then listing them just makes it a whole lot clearer and more practical to be able to do something about it, whether as opposed to going and reading about it, if that makes sense.
Do we have, Athena Ponce, you said that that it was because of some alleged cases that put this on. Is it that widespread of a problem that it is something that needs to be on here? Is it a huge trend that we've been seeing?
Athena Ponce, Assistant General Counsel. I do not want to speak specifically to enforcement's cases. But in terms of phrenotomies, for instance, I think we should keep in mind the real world circumstances that are going on, which are sometimes people offering training or classes or who are seeking to make money off of midwives and say that they're going to offer education in a certain skill so the midwife can use that in practice. And I think midwives sometimes believe, well, if this skill is being offered or this training is being offered and a midwife is teaching it, then it must be legal for me to be doing that. And there are people out there who are offering these kinds of trainings, and to my knowledge, midwives undergo them, and they don't necessarily understand that a phrenotomy comes under the category of surgical instruments being used. And midwives are not attorneys. Not every midwife out there has gone through some enforcement case where they had directly explained to them, this is how we are going to enforce our statutes, and you need to keep this in mind. And so this language is also in part to be preventive and clarifying for midwives themselves and for clients themselves, so that if they see a recommendation is made by a midwife, like, hey, I can provide this service to you, for them to understand up front, well, my form said that you can't do that, and to give them the skills to be able to ask questions and avoid those kinds of situations.
Destiny Hooper. So basically, the verbiage provides a checks and balance for the patient and midwife. So I think it falls within informed consent.
I'm neither here nor there on this language, but perhaps before this is officially adopted, maybe this could go back to the work group just for one final review now that we've had a chance to see all of the public comments that have come in that weren't previously available, just to have one last good faith read through to make sure that all of the comments are taken into consideration, and then at that point move forward with wherever it's going to go. That would be my thought. If I don't know if I need to make a motion to do that, but I can.
Athena Ponce, Assistant General Counsel. I don't think a motion needs to be made for there to be a request that the work group continue working on the form to consider the language that was suggested today and for public comments to be suggested. If Derek Burkhalter would like to chime in and say that a motion is necessary, he may do so, but to my knowledge, that's not necessary. It would rather be a work group assignment and maybe possibly again, another agenda item for the next meeting to have a report on the results of the work group for the draft form.
Hi, yeah, this is Derek, Derek Burkhalter. I don't think a vote is necessary, and the way this agenda item is phrased, it just says discussion, so it, we don't have it on there that we're gonna take any action, so I don't think a vote is necessary.
All right. I mean, that would be my thoughts. And then also just to work in that new verbiage regarding the backup midwife anyway, to just clean everything up and get a final revision. I think that would be great.
Are there any other comments to discuss about the informed consent form? All right, we will move on to the recommendations for the agenda items for the next board meeting. Carmen will write down any recommendations that you have, and you can also email her if you think of something later on after the meeting.
Michelle Gold here. I was wondering if we could get maybe a report or more details about the enforcement process. I was wondering if I could maybe ask the enforcement work group. I think Kristen mentioned this earlier, Kristen Bowers mentioned it, that they meet with the enforcement division and just kind of talk together through everything, get a little bit more information on, you know, what are those standard operating procedures that intake staff and investigators use. Mainly because the comments, whether they were positive or not, and we got a lot of them, were mainly about transparency and over the enforcement process, especially with the complaints and the investigation. So I think it would be worthy to have the work group maybe just meet with the enforcement division and see if we can get a little bit more information. You know, it was talked about that we can't talk about it here on some of the specifics, but maybe we can talk about it within the work group and get an overall report. Anybody can let me know if that's possible.
Hi, this is Derek Burkhalter. So yeah, we've heard that recommendation. You know, that's not necessarily something for the next agenda item, but that, you know, we can certainly schedule a meeting and have as much of a discussion as possible within the limitations of not discussing confidential matters and things like that.
Jennifer Keller, is there a current process or way for midwives in good standing to access closed complaints as far as what the complaint was, what the process of handling the complaint was, and what the final decision-making process in regards to that complaint was? Under transparency, is there a way for midwives to access that information other than go line by line for public records? Is there a place where they're all collected that would give midwives access, not only to grow and learn and understand, but also just to further understand the process itself and what that looks like?
So Derek Burkhalter, I'm afraid we'd have to resort to the open records process because we have to make sure that any information that leaves the agency is appropriately redacted. And the open records team are the specialists in doing that. So even if we're providing you your own information, we still have to be careful to redact it and not reveal anything confidential. And so the only way that review can occur for records to be released is through the open records process. So you know, you can limit your request so that it doesn't produce like a bulk, you know, amount of documents and just be very specific. But, you know, I think that's the process you would have to go through. Or do you think we need to add an agenda item kind of explaining that? Is that what you're recommending?
I hear a lot of chatter about, well, we used to know what all the complaints were, and we used to be able to listen to the board's feedback on how they decided as they navigated a complaint or what the resolution of that complaint was, and how much that allowed midwives to grow in their understanding and grow in their comprehensive practice tactics. And that's, you know, I realize that that was under the head of a different department completely, but I do hear a lot about, I wish we could still have access to complaints for those reasons. Or, you know, for me to request a public record on a complaint, I wouldn't even know where to start. Like, you don't know what the complaints are if you don't know what they are, right? And, or if you don't have some sort of connected affiliation to that complaint. So it's difficult to request any kind of a public record about just the broad scope complaints. Like, I see lots of forms and lots of statistics, but in order for midwives to grow in the limitations and in the parameters of rules and laws and the interpretation of those, instead of doing that through risk of complaint, that we're more proactive and learn from the complaints that have come before. Is there any avenue or any exploration of an avenue that could possibly meet that need or that desire?
Uh, this is Steve Bruno. I'll just jump in real quick, Derek, and share that I would just want to make sure you're aware we do have all of the final orders on our database. So that's a place you can go when you go to our complaint section off the home page. There's a complaints and enforcement. And then on that page, down at the bottom, there's a link called Search Disciplinary Action. And this is all administrative orders for the past, I believe, 2 fiscal years. And you can search in a variety of ways, but I recommend, as you're suggesting, you want broader information, just go and put in Midwives as the program, and then hit search. And if I see 14 results, and those have complaint numbers and summaries. But that is a place where you could certainly take that complaint number, for example, and do an open records request, so that, like you said, it's a little bit more focused to some specifics. And these, if you go to this database, you can be confident that what's shown here are final orders. So not, that it was a case that went through the entire process. And that may be helpful for you.
Thank you. That helps.
Danielle Hurst, just wanting to see if for the next agenda we could talk. There's been a lot of discussion about the complaint system. If there's a way we can talk about improving the complaint system, maybe make it more accessible. We've heard that when people call in, they get referred to the online. I'm just wondering if there's a way we can improve that, maybe for somebody who doesn't have access to the computer or doesn't understand, how to navigate. Just something to see if we can, discuss a little bit further if there's any way to improve better access to the complaint system.
Maybe that could be something that the enforcement work group reviews when we're talking about that. If during a meeting, what does this process look like? How can we make it better for consumers and collect more information?
That sounds great. That'd be excellent, actually.
That's something that we need to do, or that somebody assigns to us as the enforcement work group? Or do we just kind of like assign it ourselves? I'm not quite sure. Sorry.
Yeah, Derek Burkhalter. So staff will arrange for a work group meeting, so you don't have to schedule it on your own. It'll be scheduled through our staff, and we can go ahead and schedule that enforcement work group, and then from there, I guess, determine if it needs to be placed on the agenda for discussion with the full advisory board.
Okay,
But
awesome. Thank you.
We'll take that recommendation.
Kristen Bowers here. I would like to ask a question about statistical data. I know that in the past, we, as an organization that I'm in, we have submitted for birth certificate information. I know that's outside of TDLR, but with Texas Vital Statistics. But does TDLR have access to that? Because obviously there's neonatal outcomes on there, maternal outcomes on there, and things that we're obligated to list when we're filling out the mandated, birth certificate information. Is that stuff that is ever presented for when we're looking? I know one of the one of the comments was we need to have numbers, and people don't know what's going on, or if there is a case. Is that something that's ever pulled, or that we have access to pull? Because we did request those a long time ago as an organization, and that was over a year ago, and we still have not actually been provided that information. So it seems very hard to get a hold of.
Athena Ponce, Assistant General Counsel with TDLR. Ms. Bowers, could you say specifically what kind of information you're asking about? For instance, to my knowledge, if a birth certificate involves a midwife, is there like a check box or an indication that a midwife was involved? And if so, are you then saying, well, we would like the accumulation of all of that information that goes to vital statistics. We would like that to be set aside and be able to look at it as specific to midwives. Is that what you're saying that you would like to see?
I mean, potentially, yeah, I think that would be great. I know that when we do the drop downs, we have to select, was it a home birth intended, a home birth unintended, a birth center birth? And then in providers, we have to list who was the provider. Did they did they have care from a doctor? Did they have care from a midwife? Did they have care at all? And then it has those options to list down. It has options about what happened during their pregnancy, what happened during their birth, what happened to the baby. Did the baby have anything? When did she deliver? Where did she like, it has all of the things. So it's got a bunch of, it's very thorough. I think it's just a matter of getting it. But I mean, I think that would help better guide perhaps things that are being determined by TDLR. There can be this uh maybe community think, oh, this seems like a big problem in the community, but then when we pull data, oh well, maybe it's not really a big problem, because we are seeing in the data that it actually reports otherwise, because we all know that perception and what's actually happening may in fact be different. So I just don't know if maybe the numbers would help show, and I know that numbers have been requested, but in the past, but numbers might show how to better guide um, the Midwives Advisory Board on decision making and policy making within TDLR for midwives.
Athena Ponce, Assistant General Counsel. And the information that you're talking about that you fill out, that is specific to the birth certificate, you're saying, not the voluntary health report upon birth that people can fill out if they want to. Is that correct?
I mean, it's on the TextEver site. I fill it all out. So I mean, maybe not everyone is. I don't know if it's required. It usually flags it if I don't. So I put it all in there.
I'm sorry, this is Mike Nix. My time is now limited. I'm going to have to go and sign off. I apologize. I did not anticipate this being a 5-hour meeting. But I just wanted to sign off. And if I have any agenda things to add, I will contact back in. I don't think this constitutes a lack of quorum.
Thank you for letting us know, Dr. Nix.
Athena Ponce, Assistant General Counsel. Ms. Bowers, would you like us to follow up with you in response to your question, or would you like to maybe?
Yes, Kristen here. That would be great. I mean, just to see, because we've been unsuccessful in accessing the statistics as an independent organization. So perhaps being the Texas department might make access easier. That could be wishful thinking, but I just wanted to throw it out there.
All right, if there's no further recommendations for the next board meeting, we'll move on to J, discussion of date, time, and location of the next board meeting. Carmen will pull us over email and let us know about the future meeting. And so if there's being no further business, this meeting of the Midwives Advisory Board is now adjourned. Thank you all for your contributions and attendance, and the time is 2:55 p.m.